I welcome you all to the advanced tells us about advancement in each one of you. Now let us begin with the program. Care New Delhi, and he's going to give us
platform. And as we all know, that the more you engage, the more you learn. There's more desire to learn, and that is very critical for all of us to learn so much on day-to-day basis that I think it is really essential for professionals today to keep that ecosystem fantastic. And I think breast cancer is one of the most rapidly evolving areas. I think every aspect of oncology is developing at a fast pace, and breast is another example of it. The understanding of that is coming together for early cancer, where we see often when we are tailoring the treatment to deliver. There's so much happening. There's a lot more to learn during this process. Every aspect is being covered. Esteemed international faculty, Dr. David Hams, who is internationally known as a fantastic breast surgeon, but I think more importantly today he'll be talking about the use of, which is the selection of patients is getting even fine-tuned, where we can avoid chemotherapy. So with that, I will like to request my first speaker, Dr. Muzammil Sheikh, to talk about advanced and emerging data in ER-positive, HER2-negative advanced breast cancer. Director in Medical Oncology, Max Nanavati Hospital. And I think over the last 1.5 years, they've really built the program and the services at Max Nanavati Oncology to a next level. So Dr. Muzammil.
For the kind introduction, right?
yes, sir, but no, sir.
In ER are in a continuum with each factor impacting the other factor directly or indirectly. Grade, histology, and a single bone in the entire treatment plan may be different from a patient. So these genetic markers are not there for guiding us. Of endocrine resistance, they can either be given a chemotherapy as a frontline, and volume of disease, age of the patient, and other factors dependent upon what question remaining unanswered for those patients who progress on CDK4/6. There are a lot of trials on this aspect. We'll cover a few of them. Next slide. Like tamoxifen, aromatase inhibitors, SERDs like fulvestrant, AKT inhibitors, PARP inhibitors, some antibody drug conjugates, and immuno-oncology drugs. Next slide. So these are the, in fact, oral. So Emerald is a trial of elacestrant versus ER-positive HER2 endocrine therapy. The endpoints being PFS in all patients, and this current. So if you see this, this is interesting because based on the PFS duration on the right side, CDK4/6 inhibition. Next slide. Positive patients, those taken CDK4/6 for more than, although even for those subgroups who are 6 to 12 months or less than or more than 6 months, it's still an impressive hazard ratio of 0.51 and 0.41. Next slide. The fulvestrant injectable is any grade 4 or grade 5 TRAs. Next slide. The second trial, which I will mention, is the Serena-2 trial. It's a phase 2 trial of camizestrant versus fulvestrant in a postmenopausal ER-positive MBC. Here they have stratified as per the prior use of CDK4/6 inhibitors or lung and liver metastasis. Initially there were 4 arms, but the 300 milligram was possibly a toxic arm, so they have stopped early. However, they continued with 2 dosing of camizestrant, 75 milligram and 150 milligram, compared with fulvestrant. The primary endpoint being investigator assessed PFS. Secondary endpoints are the clinical benefit rate at week 24, ORR and OS, and safety. Next slide. And this graph clearly shows that both the dosing, 75 milligram or 150 milligram, had a clinically meaningful improvement in PFS when over fulvestrant in overall population. However, there was some degree of discordance when it was an investigator and blinded independent committee review for the PFS, particularly for the 150 milligram dose. But both this dosing schedule were better than fulvestrant. Next slide. When you see the subgroup analysis, in this subgroup analysis, whether it is prior CDK4/6 inhibition or no prior, it defines the hazard ratio in all the subgroups. So if the patient has received prior CDK4/6 inhibition, the use of 75 or 150 had an impressive 0.49 to 0.68 of an hazard ratio, versus for those who didn't have any prior CDK4/6 inhibition, it was 0.78, which again is itself and it was 0.33 and 0.55. So all these are quite impressive even for all the subgroup analysis, especially the ESR1 mutated and visceral disease. Next slide. And it achieved its endpoint, both 75 and 150 milligram of ORR and the clinical benefit rate at week 24 over fulvestrant. We can see in the middle column 11.5 versus 15 and 20, and similarly for the clinical benefit rate of almost 40 versus 51 and 48. Next slide. Again, for the safety, the 300 milligram was discontinued. The 150 and 75 milligram did have a small percentage of grade 3, grade 4 events, but not so much of drug discontinuation in the 75 milligram arm. Next slide. This is the another interesting trial, the STIC CTC. It's a very good concept-based trial design. It is first-line CTC-driven treatment versus investigator choice of treatment in hormone-positive MBC. So it was a randomized, open-label, non-inferiority phase 3 trial at 17 sites in France. Assessment was done and randomization was done based on what is the investigator's assessment for a clinical low risk or a high risk, and on the CTC count. So they were divided into two arms broadly: selection of the first line endocrine therapy or chemotherapy, which was driven by the CTC, or it was the investigator choice where the investigator decided as a clinically low or a high risk case, primary endpoint being PFS. Next slide. And this was presented in 2018 data. This was, since being a non-inferiority trial, it demonstrated non-inferiority for the PFS, whether you're using a standard or you're using CTC based. And the OS also was not very different. Next slide. Yeah.
Hello,
so if you
sir,
see
sorry to
the previous
interrupt.
slide.
Hello,
Yeah.
sir. Your voice is not proper. The voice is breaking a lot.
Okay.
Your network.
Am I audible now?
Yes, sir, you're audible.
Yeah. So go to the previous slide, please. Yeah. So this was an important graph wherein, you know, the survival result based on if the clinician felt that it was a low risk disease, but the CTC was high, and you know, and that this constituted around 25% of the population. So if your treatment was modified based on a CTC, where clinician would have not done chemotherapy or a particular therapy, and the CTC guided the therapy, you see the survival outcome based on these two. The PFS is significantly in the favor of a CTC guided or driven therapy, with PFS being 15.7 versus 10 in the standard arm with the hazard ratio of 0.65. If you see the overall survival for these patients, the CTC driven treatment decisions has been approximately 15 months, 51.1 versus 35.4 months as far as overall survival goes. So this also is the food for thought. The problem with this trial was that it was done in the era where CDK4/6 inhibitor were not the standard of care in the front line. However, you know, with the CDK4/6 being used commonly in clinical practice, maybe this CTC-driven treatment decisions post-progression of a CDK4/6 inhibitor can be really meaningful and useful, because most of the second-line endocrine therapy single agent are very short-lived benefits. So it may help us in making a decision for using chemotherapy early in a patient who progresses on a CDK4/6 inhibitor. Next slide. Next slide. So across all these subgroups, same is shown in a forest on the right side. If the clinical suspicion was low, but the CTC was high and the therapy was modified across all subgroup of patients, all favored the CTC driven treatment decision for all these patients. Next slide. This is another important trial, right choice, ribociclib plus endocrine therapy versus combination chemotherapy in aggressive hormone positive MBC. Aggressive meaning those in visceral crisis, marked symptomatic non-visceral disease or impending visceral function. So this we are aware that, for a visceral crisis, we jump to giving chemotherapy first. Last few years has seen accumulation of data for using a CDK4/6 inhibitor in certain visceral crisis. Now, this was a phase 2 multinational study stratified by liver metastasis and a DFI of less than more than 2 years to ribociclib plus endocrine therapy versus investigator choice of combination of Priyanshi.
Yes, sir.
Slide change, please.
Yes.
So this was the primary PFS endpoint. Ribociclib compared to the combination chemotherapy, the median PFS was 24 versus 12.3 with an impressive hazard ratio of 0.54, which simply says that not all patients in visceral crisis needs a combination chemotherapy. Next slide. Now the time to treatment failure, the failure rates were much lesser in the ribociclib plus endocrine therapy arm, and also the median time to treatment failure was 18.6 months versus 8.5 months in the favor of the ribociclib plus endocrine therapy arm. Next slide. Similarly was the clinical benefit rate and also the time to response. Time to response was slightly faster as expected in the combination chemotherapy arm. Next slide. Next slide, please. Regarding the side effects, we are using this CDK4/6 group of drugs. Not much of issues with these drugs. When you compare chemotherapy, the number of dose reductions definitely were much more in combination chemotherapy. Next slide. So again, there were neutropenias more in ribociclib, but none of them were febrile neutropenia. Next slide. This is another interesting trial, Captello 291. It is capivasertib plus fulvestrant versus placebo plus fulvestrant in an endocrine resistant hormone positive metastatic breast cancer. So capivasertib is an oral inhibitor of AKT 1, 2, and 3. When in combination with fulvestrant, it significantly prolonged the PFS and OS in patients who are AI resistant and no prior CDK4/6 in the FACTION trial. So Captello 291 was an international randomized double-blind phase 3 trial where this group of patients were randomized into capivasertib plus fulvestrant versus placebo with fulvestrant, with the 12 primary endpoint being investigator assessed PFS in the overall population and also an enriched population of AKT pathway altered tumors where any of more than one qualifying events were taken as an altered pathway like PI3K, AKT1 or P10. Secondary endpoint were OS and ORR. Next slide. And this graph clearly shows that early separation of the curves and the separation is maintained. So the median PFS was 7.2 months versus 3.6 months with a hazard ratio of 0.6 in the favor of the oral AKT inhibitor with fulvestrant. Next slide. And this was the investigator assessed PFS in the AKT altered or the enriched population where 7.3 versus 3.1 months and hazard ratio of 0.50. So it met the dual endpoint of PFS in both the overall population and the AKT altered population. Even in the non-altered population, the hazard ratio was 0.70, which was quite impressive. Next slide. So the forest plots clearly says that all subgroup did get benefit, including the exploratory liver metastasis and the prior use of CDK4/6 inhibitors. These two groups also got benefited by using a Capi plus fulvestrant. Next slide. And this actually is an immature data. It is at 28% maturity of the overall population, but still the overall population, if you see the overall survival, it is 0.74, and if you see a enriched population of AKT pathway altered population is 0.69, both showing a trend towards a favorable overall survival in the AKT pathway arm. Next slide. This is the fifth study, PACE, fulvestrant plus minus palbociclib after progression on a CDK4/6 inhibitor and endocrine therapy in a HR positive patient. And this had actually three arms. Fulvestrant was compared with fulvestrant plus palbociclib versus fulvestrant plus palbociclib plus avelumab, which is an immuno drug checkpoint inhibitor. Next slide. And clearly the triplet arm of fulvestrant, palbociclib and avelumab had done better as far as the 6-month PFS is concerned, 50% versus 40%, and the 12-month PFS is 35% versus 13 and 17% respectively. Next slide. So based on the baseline mutation, the exploratory analysis was done. So if you see the mutational status, the fulvestrant plus palbociclib arm was more favorable for those who had either PI3K mutation or a ESR1 mutation or even a retinoblastoma RB1 mutation. Next slide. Similarly was true for, based on the overall measurable disease and the clinical benefit rate. The triplet had a slightly better response rates as compared to fulvestrant single agent or combined with palbociclib. Next slide. This is the last one, TROPiCS 2. This is saxizumab govitecan versus treatment of physician choice in a hormone positive HER2 negative MBC. It was a randomized multi-center phase 3 study stratified based on the visceral metastasis endocrine therapy in metastatic setting more than 6 months or prior chemotherapy lines, heavily pretreated 2 or 3 or 4 lines. They were randomized into saxizumab govitecan 10 milligram per kg for day 1 and 8 every 21 days, or the physician choice of treatment, which can be capecitabine, vinorelbine, gem, or eribulin. Primary endpoint was PFS. Secondary endpoint was OS and ORR. The current exploratory analysis was to evaluate the impact of TROP2 expression on efficacy based on a IST score or H score. TROP2 is a surface marker which is expressed on most of the solid tumors. Almost 90% of breast cancer will have this expression. Next slide, please. And it was evident that across all, so irrespective of the troponin 2 expression level as per the H score, saxizumab govitecan was preferred over the physician choice treatment. Next slide. This was for the PFS, and similar observation was also made in the overall survival graphs. Next slide. So I will just sum up the entire update for the HR positive advanced breast cancer. In the EMERALD, longer duration of prior CDK4/6 therapy correlated with a longer PFS with subsequent oral SERD versus standard of care, especially for patient with an ESR1 mutation. The median PFS was 8.6 months versus 2.1 with elacestrant versus SOC. And for patient with ESR1 mutation, more than 18 months of prior CDK4/6 inhibitor therapy. In SERENA 2, we saw that camizestrant 75 or 150 both was associated with a PFS benefit over fulvestrant in the previously treated postmenopausal ER positive ABCs. Camizestrant was well tolerated at both doses with infrequent more than grade 3 TRAEs and dose reductions and discontinuations. Next slide. In this TRIC CTC, it was the first prospective trial supporting the clinical utility of a circulating tumor cell count in ER positive MBC for clinically low but CTC high, which was 25% of the clinical trial population. Median OS benefit of almost 16 months was in the favor of the CTC driven therapy decision making. For clinically high but CTC was low, which was 13% of the population, no OS benefit of chemotherapy versus ET. So ET confirmed as a standard of care, which means it was a non-inferiority. The choice of ET versus chemotherapy is still unclear for patients who received CDK4/6 inhibitor as an adjuvant for the first line therapy, as the CDK4/6 inhibitors were not approved at the time of accrual, but now they are standard of care. However, this can become as an option for deciding second line therapy after CDK4/6 inhibitors. The next trial was Right Choice, first prospective demonstration of PFS benefit from a CDK4/6 inhibitor plus endocrine therapy versus combination chemo in a pre-perimenopausal female advanced ER positive breast cancer with an aggressive, rapidly progressing, high symptomatic disease, PFS of 24 versus 12.3 months, hazard ratio of 0.54. So this and the time to treatment failure also was longer in the ribociclib plus endocrine arm. Next slide. Next slide, please. The Capitello 291, in which previous slide, the Capitello 291, in which the endocrine resistant ER positive patients, capivasertib plus fulvestrant significantly prolonged the PFS versus placebo plus fulvestrant in overall and also the AKT altered patient population. PFS was consistent across all groups, including those who have got earlier CDK4/6 inhibitor and those with liver metastasis. In the PACE trial, addition of palbociclib to fulvestrant did not significantly improve PFS compared to fulvestrant alone, but those who have added avelumab had a better response rates. In the TROPiCS-02 trial, the exploratory analysis confirmed efficacy of sacituzumab govitecan across all TROP2 expression levels. Even those with a very low level of expression, ER positive, has benefited with use of the SG. I think I will end my talk here. Thank you so much.
Thank you, Dr. Muzammal, for that very lucid presentation. I think it's quite elaborate, and we'll go through the questions in the panel discussion. May I request Dr. Garvit is there, Dr. Garvit and Dr. Mandar Nadkarni. They are Dr. Yeah.
Good evening.
They're the program directors, so I'll request them to please take over. Dr. Mandar is there. Good evening, Dr. Mandar. Good to see you. He is the senior surgeon at Kokilaben. Yes, at Kokilaben, and he's a breast and GI surgeon, and Garvit is at Max Nanavati. So I'll request them to please take over from here. Thank you. Thank you. I'm here.
We are going for the talk, are we right now?
Yeah, talk by Dr. Ashish.
Okay. Garvit.
Yeah, I'll do the needful. So, good evening, everyone. And let me have the pleasure of inviting Dr. Ashish Singh, who is an associate professor in Department of Medical Oncology at CMC Vellore. And he would be making a presentation on tailoring treatment in HER2 positive advanced breast cancer. Dr. Ashish.
Yeah, hi, good evening. Someone just confirm if I'm audible and slides are visible. I'm sharing my screen.
You're audible, but the slides are not visible yet.
Okay, I'll just share the screen. Is it okay now?
Not yet. We can see you, but not the slides. Can someone from the technical team help? Mice ideas?
Yes, sir. Could we share your slides?
Is it okay now? Just try that. I think some settings on my.
No, sir. It is not visible yet.
just one more try, and then if I'm not able to,
Yeah,
then
yeah. Okay.
is it okay?
Yes, sir. Yes, sir. Now it
Yeah.
is
Okay.
visible.
So sorry for the glitch. So good evening, friends. Thank you for the invitation. And so I've got 10 to 15 minutes, and my job is to take you through updates, recent or rather recent updates in the management of HER2 positive advanced breast cancer. Now we know advanced breast cancer, especially the HER2 positive, as such was not a different entity. Only after maybe 1998, when we know that this drug trastuzumab was discovered, which would block HER2 signaling. Now HER2 was an important biomarker. It was detected way back in 1980s in Dr. Sleman's lab, but we particularly learned to target this pathway or this receptor only in the 1990s. Now, I mean, it's we all know the story how trastuzumab actually has revolutionized management of early breast cancer. Now, in terms of advanced breast cancer, for a long time after discovery of trastuzumab, we did not have any other advance except for lapatinib. Now, lapatinib was a tyrosine kinase inhibitor, multi-kinase inhibitor, particularly inhibits EGFR, including HER2. Now, after about a few years, we learned actually how to use pertuzumab. Now, pertuzumab was discovered earlier, but as a single agent, it was not better than trastuzumab. It actually did not have much activity. It's only when we combine it with trastuzumab, then we learned this is the best way to use it. Then the field evolved. In 2013, out came the ADCs. The first one was trastuzumab emtansine, and then of late in the last, I'll say for 3 or 4 years, we have seen newer ADCs and newer TKIs. Now, what is so interesting about this is that this is just one particular pathway which we are inhibiting, and in spite of the disease developing resistance to one treatment over the other, it remains addicted to this pathway. And this is very different. I mean, we hardly have, like, for example, if you talk about gastric cancer, which are HER2 positive, the moment they become resistant to trastuzumab and chemotherapy, subsequent anti-HER2 therapies do not make too much impact. But that's not so in breast cancer. So it's in a way it's a truly, we should say, addicted disease, or a true driving mutation which causes this cancer. Now, Cleopatra trial, we are all aware of the data. Now, this was the first time it was shown that a dual HER2 blockade using both pertuzumab and trastuzumab not only improve progression-free survival, but also overall survival. Now, in a disease where there are multiple lines of options available, improving overall survival is sometimes we don't see with many of the other agents which are less effective. But as a gold standard, if you see here, an improvement is almost the delta is almost 15.7 months. That's a huge improvement, and this is irrespective of whether the patients are ER positive or ER negative. Now, more interestingly than just improving overall survival, more than just a statistical significance, is when you look at the progression-free survival curve, and this is a longer follow-up. And if you look at even at 5 years or even at 6 years, almost up to 15 to 20% of these patients, some of them are actually progression free. So what does it mean? It means that they have just received 6 cycles of docetaxel and then followed by just this monoclonal antibodies, and their disease has not progressed. So is it possible that some of these patients are actually cured of their disease, right? Because if they had resistant clones, it would have crept up over the next few years. Now, and if you look at the long-term overall survival, that's about 37%. That's and that number is around 40-45% at the 60 months mark. So it's not only that we are making these patients live longer, we are making these patients live without cytotoxic therapy, and there is a potential that some of these patients with aggressive multimodal management, they may even be cured. And then there are trials now designed trying to explore this area, especially incorporating the newer ADCs, including the brain penetrance tyrosine kinase inhibitor. Now, is docetaxel the only taxane we should use with? The answer is no. There is a lot of work done which shows that even if you can use nab-paclitaxel or paclitaxel, you do not compromise on the efficacy of trastuzumab or pertuzumab. Now, also there is there's a study called PERTAIN which showed that that in patients who have ER positive disease, combining pertuzumab to trastuzumab as maintenance strategy. Some of these patients would have received chemotherapy before. It does improve event-free survival or progression-free survival. Does it actually improve overall survival? Some numerical difference, but not statistically significant. And also, if you ask me as a clinician, if I have to use a drug like pertuzumab, I would rather use it with a taxane and not with just endocrine therapy, unless the patient is so frail that we don't think that that's an option. Even in older frail women, weekly paclitaxel 8 to 9 cycles or even up to 12 weeks is a well-tolerated regimen. And looking at the survival curves of the Cleopatra trial, definitely they look much better than this PERTAIN results. And so now moving ahead, anything else we can do in first line? There have been trials which are trying to combine immunotherapy. Also, there are trials which are trying to combine CDK4/6 inhibitors. Recently, we have seen data with the MONARCH-HER trial where abemaciclib, in addition to trastuzumab as well as aromatase inhibitor, has shown better PFS. So whether CDK4/6 inhibitor has a role, maybe, but we still have to wait for readouts of these other trials like PATHINA trial and even trials with ribociclib. Now, some of these patients may carry a PIK3CA mutation. In these patients, definitely alpelisib is a toxic drug. One would not want to combine it during chemotherapy phase, but after chemotherapy is over, is there a role? The answer is we do not know. We need trials, and those trials are still in the pipeline. Now, eventually, some patients will progress. Once they progress, what is our go-to treatment, right? Now, before the ADCs came, lapatinib established itself to be the standard of care along with capecitabine. And some people would continue trastuzumab along with this combination, and some would probably not, just capecitabine, lapatinib. So TDM1 was able to show itself to be superior to LAP-CAP combination. And this is in terms of overall survival and also in terms of toxicity. The diarrhea, the mucositis, fatigue is definitely lesser with an ADC. That's because the chemotherapy is selectively delivered. And this was before we seen data with other ADCs that TDM1 was the only ADCs we had, and it was way better. Only recently we have as technology has improved, our understanding has improved. So we have a new ADC called trastuzumab deruxtecan. How is it different from TDM1? It's different in a way that, first of all, the cytotoxic agent is a irinotecan derivative. Second thing is the drug to antibody ratio. It carries much higher low payload. Third thing is that the linker is cleavable. So once the antibody attaches to the cell and the payload is delivered, this payload actually is able to come out of the cells, come out of the dying cells, and produces what we call a surrounding, it's called a bystander effect. So not only it targets HER2 positive cells, but also targets HER2 negative cells or HER2 low positive cells in the surrounding. And that could be the reason why we are seeing such impressive responses. And also that could also be a reason that this ADC is more toxic than the TDM1 what we have. Toxicity aside, that we will learn how to manage, but the efficacy definitely looks much superior to TDM1. And this is a head-on trial, DESTINY-Breast03, which is the primary endpoint. If you see a hazard ratio of 0.28, and these are all patients who have had prior 1 to 2 lines of therapy. And in such a population, pre-treated population, if you have a 1-year PFS of 75.8, which is as compared to only 35% in TDM1, this is definitely a way superior drug to TDM1. Now Now, whether this is a large ADC like a monoclonal antibody, so does it have efficacy in the brain? Now, only subgroup analysis. Also, mind you that all these patients obviously are very fit patients. They've had their CNS disease treated before they go into the trial. And if you look at the forest plot, I mean, almost every subgroup, whether you have brain metastasis or no brain metastasis, the magnitude of benefit is almost similar. Not only PFS, this drug also has improved overall survival in the longer follow-up. And in the West, it is currently the go-to treatment or the standard of care. But I know this is probably one of the costliest drug in the market, even in the West. And even when it becomes available in India, I'm not sure it's going to reach how many of our patients, right? So even though we are making progress, we still have to better utilize the older available drugs what we have, that is lapatinib, capecitabine, or TDM1. And it is good to see that this drug retains its efficacy even after patients progress on TDM1 and LabCat. So for some patients, maybe at a later date, if you use this, you may get away with lesser number of cycles with equal efficacy. But the response rate, just look at the response rate, a confirmed ORR of almost 80%. This is in later line. 80% ORR in later line is extremely good, with a CR rate of almost about 16%. So we all have lapatinib, we all use lapatinib. So do we need another TKI? So another TKI here is tucatinib, right? Now the argument given to design this trial is tucatinib probably has better CNS penetration. It may be better tolerated, and nevertheless, the company decided to test it out against placebo. Now that's the problem with this trial design. I mean, if I was the patient going into this trial, I would probably want to get lapatinib if I go into the placebo, to the control arm. But that was not how this trial was conducted. Almost 410 patients were randomized. Untreated brain metastases were allowed, but they were all asymptomatic patients or patients who were not on very high dose of steroids. Now, if you look at progression-free survival, the median progression-free survival 5.6 months. In the control improved to about 7.8 months. And so that is only about 2.2 months. But the median OS in the overall intent to treat the difference was about 4.5 months. And in the longer follow-up, about a 5 months improvement in overall survival, about a delta of about 10% at 2 years. And this is predominantly, I would say, it's probably at this point in time, most of the patients are actually having CNS disease, or the risk of dying with CNS disease is pretty high. And this drug is extremely good, obviously, because it's designed to penetrate the brain and small molecule. So if you look at 1 year progression-free survival of about 25% in the brain is pretty okay, and 6 months was about 60%. And 1 year's overall survival was about 70%. Now, so the response rate in the brain is about 50%, and the median PFS in the brain is about 9.5 months in this thing. Now, if you add tucatinib to capecitabine, definitely you will get more toxicity over and above what you get with capecitabine. And the common ones are nausea, fatigue, hand-foot syndrome, and diarrhea. And the diarrhea incidence can be as high as 80%. So it is not that it's going to be an easy drug to use, but we are all familiar with how to adjust the dosage and we all start low and go up, especially with capecitabine. So in summary, I mean, we do have so many chemotherapy-free options, I would say. But just because they're chemotherapy-free doesn't mean they are very well tolerated or they're not toxic at all. They all have their unique toxicities. They all, especially with trastuzumab deruxtecan, we'll have to learn how to manage the pneumonitis. We'll have to learn how to kind of what is the correct dose in our population, because all those things we will learn when the drug comes here. But till the drug comes here, we do have all the other available options. Pertuzumab, it belongs to the first line. Subsequent lines therapy, I think we decide based on presence of brain metastasis or no. If there is a brain metastasis, we would definitely want a TKI in the armamentarium, which could be lapatinib, because tucatinib is still not available. TDM1 still remains a very good option for our patients, and knowing that TDXD is something which we can always fall back upon. But if your patient can access TDXD in second line, nothing like it. And I'm sure in the coming few years, we will see this TDXD will be giving tough competition even to pertuzumab, trastuzumab, and taxane in the first line. Those trials will be reported in a few years. Once patients progress on these options, we also can go back again to drugs like neratinib or lapatinib if we have not used early. And along with this, with other maybe CDK4/6 inhibitor, maybe immunotherapy in future, who knows? Those trials are ongoing. So this is really has been a revolution in management of HER2 positive MBC. Thank you. Thank you for your attention.
Thank you very much, Dr. Ashish. That was a very lucid presentation and on a very evolving and a difficult topic right now because especially with deruxtecan, and now since the last ASCO, the low HER2 score suddenly coming into treatment worthy disease, it becomes a little more difficult to understand this disease, HER2 positive breast cancer. But anyway, without wasting much time, and let me invite Dr. Devrat Arya, who will be now conducting a panel on HER2 positive and HR positive breast cancer. Dr. Devrat Arya is Director, Department of Medical Oncology at Max Hospital, Delhi. And I'm grateful to him for having taken the time out to conduct this and moderate this panel. Dr. Arya.
Yes, thank you very much.
Should I invite Dr. Arya? Would you want me to invite the panelist, or would you do that?
Yes, please go ahead.
Okay. Dr. Muzammil had to leave because he had an emergency, and that's why Dr. Ashish Singh, Dr. Advait Gore, who's the Associate Director at Nanavati in Medical Oncology at Nanavati Max Institute of Cancer Care, Dr. Bhuvan Chugh, who is a Senior Consultant with Max Hospital, Dr. Sachin Gupta, Dr. Aditi Chaturvedi, and I'll be part of the panel. Dr. Aditi Chaturvedi is also a consultant surgical oncologist at Max Gurgaon, and Dr. Sachin Gupta is a medical oncologist, Director of Medical Oncology in Max Mohali. Correct me if I'm wrong, I'm really sorry because I don't have all your CVs. Dr. Arya, please go ahead.
Okay, thank you very much. I hope my slides are visible.
Your slides are visible.
Okay, so I think first of all, I have to commend initially Dr. Muzammil.
So just a second, Dr. Bhuvan is there in the attendees part. Priyanshi, can you add
Yes,
him?
I'm sorry, I have not seen. Dr. Bhuvan Chugh, who is also on the panel.
Yeah, he's in the attendee sheet. We have to add him into the panel. Yeah, he's added.
I was adding him, but he didn't accept it. Now he's there in the panel.
Okay, fair enough. Dr. Bhuvan Chugh, who's Senior Consultant in Medical Oncology, has also joined the panel. Sir, please go ahead.
Okay, so thank you, and I hope my slides are visible.
Yes, they are.
Yeah, okay, so I think I was trying to commend the previous speakers, Dr. Muzammil and Dr. Ashish, for doing an excellent job of the recent updates in the fields of both the HR positive and the HER2 positive subset. And I think that limits me to very few questions, and I'll quickly go to these questions. So, okay, so let's discuss this case. So, typical case, let's not go too much into the details. So, lump in left breast, initial biopsy, grade 3 tumor, but it was ER and PR 6/8 and HER2 3+. PET scan confirmed disease in the left breast with left axillary nodes. Unfortunately, the patient also had multiple lung nodules, liver mets, no visceral crisis. CBC, KFT, LFT is normal. I think we've heard the data of Cleopatra, we all know, and I think the standard treatment for most of these patients is chemotherapy with trastuzumab and pertuzumab. So we heard Dr. Ashish's comments on the second question, but I'll get back to some of my other panelists. So I'll probably start with Bhuvan. So Bhuvan, is there any patient in your practice who's HER2 positive, who you would, are fairly happy doing hormone therapy with trastuzumab and pertuzumab? We did listen to the results of PERTAIN. The addition of pertuzumab did add benefit to trastuzumab and pertuzumab. So any patient whom you're happy starting hormone therapy, or is it only on patient request?
So I think I'll obviously factor in the patient's condition. If there is an elderly patient who, possibly a late 70s, has a limited amount of disease, has a strong hormone positive disease, I possibly may think of adding HT along with HER2 therapy and be happy with it. So I think possibly somebody whom you feel that it'll be a single agent weekly Taxol also may be very, very toxic. I think the sect of that patient will be very small, but then yes, those are the only patients.
So select few patients. Any thoughts, Dr. Sachin?
Yeah, Devraj. So there could be few patients who are very elderly and have too many comorbidities and who totally refuse to come to hospital. There are some patients who are not willing. So we have options of subcutaneous. This combination Phesgo is there that can be combined with the hormonal therapy, and also there is some data with the oral cyclophosphamide. That's also interesting, where the good benefit has been seen, and also CDK4/6 inhibitors in combination with anti-HER2 regimens. So that makes things even more interesting actually, and the data is also exciting. And in some of these patients, although we are used to giving chemotherapy and we love to use taxanes upfront, but and there is no head-to-head comparison between taxanes with anti-HER2 versus CDK4/6 inhibitors with AI plus anti-HER2. So once we have that clarity in coming years, that it may simplify things to more of oral treatment with subcutaneous anti-HER2 treatment.
Yeah, so 2 points here. I think we do have the Monarch study. This was a small study with a very heavily pretreated population. We do know that the combination of fulvestrant, abemaciclib along with trastuzumab did work fairly okay. I think the median PFS was about 8 months or thereabouts. And I think we've all had patients in our practices where a combination of chemo plus anti-HER2 or even TDM1 doesn't work at all, and sometimes this combination does. But I do suspect that for majority of our patients, it's chemo plus trastuzumab and pertuzumab. But I think we all have a select few patients who would, on account of their fragility or their choice, would perhaps be offered hormone therapy. I think what stands out between Cleopatra and the PERTAIN study is how the curves converge. So in Cleopatra, the curves perhaps never converge. So there's always a gap. And I think I agree with Dr. Ashish Singh's comment that there perhaps is a subset of patient, and we saw that about 16% at 5 years, correct me if I'm wrong, disease-free on maintenance pertuzumab. We all see such patients in our practices. However, the curves did converge fairly quickly in PERTAIN, which means that majority of these patients eventually were progressing, and you're actually creating very small number of patients who who really didn't progress for a long time. We had the Marianne study, and I think in this era of all these new drugs, Marianne seems an archaic study. But any of us picks up TDM1 as a first line? Dr. Adwaita, let me bring you in the discussion. So your thoughts on Marianne? Is it absolutely no choice? So I haven't used it, but what are your thoughts?
So very frankly, I haven't used TDM1 in this situation in my practice. Most of us are sticking to the trastuzumab plus chemo or trastuzumab plus hormone for the frail ones. So another thing which I'm worried about is offering pertuzumab to very frail patients, especially because the diarrhea which is commonly seen. Many a times these frail elderly patients do not tolerate pertuzumab very well, especially when given in combination. So there are practical difficulties in clinical practice versus clinical trial scenario where you do get fit patients. And I think we should be extrapolating that data to elderly patients very, very cautiously, because we burnt our fingers once or twice giving the combination to patients and they've landed up with shock because of the extensive diarrhea because of pertuzumab. So that definitely would be with caution. On the TDM1, I haven't really used, so I can't really comment on that.
But I think the data does appear to bring out the fact that the addition of pertuzumab adds efficacy to whatever you're using, right?
Yes,
So
yes, it
whether
definitely
it's
does. It
yeah,
definitely
so
does. Yes.
and so I think if cost is not an issue, we'd all
Yeah.
perhaps end up using it. Although I agree, diarrhea can be an issue in select number of patients. But if the patient can afford it, we would perhaps end up using it. I think we had this the other study, which was the CIS-UCC-002 trial. So basically, this was a study where they were trying to compare trastuzumab along with hormone therapy versus or trastuzumab, pertuzumab along with hormone therapy versus taxane plus hormone therapy, and this was a non-inferiority trial, and they did suggest non-inferiority. But I think all of us do agree that if given a choice, we would end up using chemo. Now, the other thing is which chemo and Dr. Muzammil did talk about, or in fact, sorry, Dr. Ashish did talk about the Peru study, and I think it brings out something that we've been doing for ages, I guess. While Cleopatra was docetaxel, trastuzumab, pertuzumab, I think we've all been using paclitaxel or nab-paclitaxel mostly in a weekly setting. Moving ahead, so this patient was started on paclitaxel, trastuzumab, pertuzumab, responded very well. After 18 weeks, 9 weeks partial response, 18 weeks disease remained stable compared to the interim scan, and was on maintenance trastuzumab and pertuzumab, completed about 20 cycles, and at this time had new onset headache. MRI brain suggested single lesion in the left occipital lobe with minimal surrounding edema. The PET at this time, which was done to rule out systemic progression, showed a stable disease elsewhere. Now the question to my panelists again. Now this is a symptomatic patient, right? Now let's twist the situation. I'll start with Dr. Sachin. Had this patient been asymptomatic, what is your practice? And I know we've discussed data of tucatinib, TDXT, TDM1, perhaps a little data of neratinib as well. What is your practice? Asymptomatic brain mets, how do you approach?
So for a single brain metastasis, which is asymptomatic and a smaller one, I would actually, continue with systemic treatment and bring in more agents. So since TDXT is not available and costly, and let's not consider those things. Tucatinib is again not available and, beyond means of most of us. And so the choices would be, something like TDM1, which would be, a lot of times generic, and also lapatinib with capecitabine. Or, we change trastuzumab, pertuzumab, and change the chemotherapy arm. So that could be other practice. And if the size of the lesion is bigger, one has edema also, I would love to give SBRT first, tackle the brain lesion first, and then, continue with the systemic treatment. And in this case, we have choice of, adding hormonal, hormonal agents as well, since your patient is ERPR positive. So I like to bring in those agents as well here.
Dr. Adwaita, your thoughts? What do you do in your practice?
So in a patient who's asymptomatic with a solitary brain metastasis, we would change the systemic therapy, may not go in for radiation immediately. Given the choices, TDM1 with a better CNS penetration, with a better PFS benefit as compared to LabCape would be the correct choice. Neratinib, yes, again, the issue about the toxicity, the diarrhea with neratinib comes in. And again, it is not really, on a practical level, it's not really affordable for many patients to take. In a patient who has, now if you look at two scenarios in which the patient does not have CNS metastasis and just a solitary, say a lung or a liver nodule, I might look at a local treatment for the lung or the liver nodule and continue the current trastuzumab, pertuzumab, and observe this patient very closely. But in CNS, it becomes a different ballgame where you know that if you don't act fast, the survival is going to be short.
Dr. Ashish, your thoughts?
Yes, I think the most important thing is whether the CNS disease is symptomatic, not symptomatic, whether many times, even though we think about this blood-brain barrier and whether these large monoclonal antibodies would penetrate, but many times when there is a tumor, there is actually no blood-brain barrier in the tumor. So larger tumors, multiple tumors, we will end up doing radiation first. And we have had so many patients after radiation. They are having reasonably well disease control, even on TDM1. And now even the data with TDXT is also convincing that just because the disease is there in the brain, you don't have to jump to a TKI. But if the patient cannot afford these ADCs, then definitely lapatinib or tucatinib should be there in the treatment plan. And many of us, sometimes you would even go with capecitabine because of better CNS penetration.
So what I understand from the discussion so far, Doctor, that all of us for asymptomatic brain mets, even though there's no evidence of progression systemically, are quite keen to switch over to an alternative CNS penetrating agent. That's what seems to be coming out.
No, so I don't agree with that. I think
I'm coming to you, Bhuvan. I'm coming to you. I'm coming to you. I know I haven't come to you. So and this is with the knowledge that for some of these patients who are on trastuzumab, pertuzumab, they may be doing fairly well, and we do know that switching to any of these alternatives, particularly the ones that are available in India, they can be slightly more toxic options. So Bhuvan, now coming to you. I am somebody.
The biggest fear we all have is, I mean, I see the argument is, can we just radiate the brain and continue with trastuzumab, pertuzumab? The biggest fear as a clinician, what I have is, what if in 3 months down the line you have leptomeningeal disease or CSF positive disease? That will be a very bad situation to be in, and there is not enough. I mean, I would say there's not enough experience or published literature which has studied what we are just talking about, saying radiate and don't do anything new.
Correct.
That will be, yeah.
That's why we are discussing it. But I think you've raised a fair point. Nobody knows the efficacy of these agents in leptomeningeal disease. We do have some data for tucatinib. There does seem to be some efficacy for leptomeningeal disease. But Bhuvan, your thoughts?
So I think what we should take into account is also how long has it been on the HNP. So if a patient has done fairly,
she finished 22 cycles, so that's more than a year of maintenance.
So
that's
more,
about,
so it's almost year and a half. If the
half.
patient is doing well, if the patient is doing well, if there is a single isolated met, I do understand that there may be a fear of going into a leptomeninges, but a single asymptomatic brain met, especially considering that at present, as of now, there are not unlimited choices of anti-HER2 agents. I probably would want to continue an HNP for, at least for a while after giving SBRT to the brain lesion. I think that would be my approach to it.
Yeah, so I guess there's no right or wrong here, but I tend to agree. So what I do in my practice is I would actually give SRS, SBRT, keep on monitoring fairly quickly at perhaps 2-3 monthly MRs, continue the same maintenance. While there is some data, we do know TDM1 has some CNS penetration. Intracranial responses have varied from anywhere between 20 to 25%. Perhaps there are smaller studies showing a higher intracranial response. We do feel that capecitabine and lapatinib does have CNS penetration, although we haven't had very robust data to support that. And I do feel that with tucatinib and TDXT not being available, I think our hands are fairly tied up. So this is what I did for this patient, and the patient remained free of CNS progression for a year. One could say she got lucky, but she did progress again. And this time again, symptomatic brain mets on the opposite side. And this is when I actually switched to TDM1 as well. And no evidence of systemic progression. The patient is very unhappy with the TDM1. But I guess those are the questions that we face as medical oncologists as to when to switch for a regimen which is acting systemically but may not be that CNS active. Now, we did hear Dr. Ashish talk about the Destiny Breast 03. I think the data is fairly compelling. The hazard ratio, when you look at PFS, is very similar to what we saw in the Cleopatra study. And one could say that the TDM1 arm didn't perform as well as it did in the Amelia trial, which was the second-line registration trial for TDM1. But I think the problem that we've had, and I don't know if the panelists would agree, is that in my experience, the efficacy of TDM1 in a post-pertuzumab setting has not been that well. In fact, most of my patients haven't done well, and I think there's some retrospective data to support that. there does seem to be toxicity. But I'll get back to the same question. Dr. Sachin, if TDXT were to be available, pertuzumab is not cheap either. And we do know that we may have TDXT sometime soon outside of clinical trial setting. If it's available, do you think it's going to be your second choice regimen? I think it's beating the doors. Yep, absolutely or not?
Absolutely, yes.
Absolutely, yes.
The data is too convincing actually, with the hazard ratios and the difference in PFS and the survival rates. It does make sense to put it into the second line, as soon as it is available.
Dr. Adwaita, your thoughts?
TDXT would be, I think it is eventually going to replace where we use TDM1 as of today. I think it's a better payload, a better delivery of the drug, a better combination together, because we've seen that imlunestrant is not a great chemotherapeutic agent. And I think it is going to be there for a longer period of time as compared to TDM1.
I think the concern is ILD, and in some of the studies you actually see grade 3 for ILDs not very high at about 3%, but any grade ILD up to 25%. And I guess in a real world setting, picking up an asymptomatic grade 1 pneumonitis becomes a huge challenge. You don't usually do that, right? So I think that's a concern, but I do believe that this could be a drug which could potentially be a first line agent as well. I think we all have to wait for that data. But I do feel that when used appropriately, I think TDXT is something that we are all excited about. Bhuvan, your thoughts on some of the other drugs that are available? I know tucatinib is not available. A couple of our patients have had access to it and seem to be doing fairly okay. It does appear to be
just while we are in a meeting, there's a patient who has tucatinib left, and the patient has died. If somebody needs it, please tell me. But then coming back to it, the thing is, we all are waiting for TDXT, and I think the price point which possibly the company told us, it's somewhere near the pertuzumab. I really don't think any of us are not going to shift to it. But yes, I do share your concerns of ILD. I don't know. A few of my HER2 patients have had ILDs, and it obviously scares you. How do you manage the ILD in such patients? And I think that'll be a learning curve for all of us.
Right. So I think we are short of time, and we have two surgical oncologists on the panel. So I come to you, Garvit. Dr. Garvit, we've all debated the role of surgery from primary for metastatic disease. I think we've recently had a study where radiation to the metastatic sites also failed to yield advantage. Do you see any role of surgery in oligometastatic disease, and first in a HER2 positive setting, and I know it's tricky, and then in a HR positive HER2 negative setting?
So irrespective of the IHC, when we are talking about oligometastatic disease, I think there is a role. So when you see data, there's a line which goes between the frankly metastatic disease and locally advanced breast cancer, or I'm talking about the survival curves, and that is irrespective of the IHC of the disease. Where when it is oligometastatic, and I know the definition of oligometastatic itself is gray, and there are about 3 or 4 definitions which have come out, and based on the latest this thing also, I believe that we should be able to treat it with a curative intent and hope for the best, that it stays in the realm of curative intent for as long as possible, and then whenever it becomes metastatic, it obviously will at some point of time. But yes, there is a definite role of surgery, not just to the primary. There is a role of surgery to this. If you're not able to radiate the secondary site or surgically remove like a pulmonary met, which is a solitary pulmonary met, it can be either SBRT'd or can be obviously a small metastatectomy can be done. A small liver lesion can be either you can radiate it or remove the lesion.
Now, the other issue that we have, especially in a HR positive and HER2 negative setting, is obviously for a HER2 positive setting, it's fairly simple. You start with chemo and anti-HER2. You choose patients who are responding very well, probably decide whether you want to offer surgery. But this situation is slightly different in a HR positive population, because most of these patients even in a oligometastatic setting could perhaps be doing fairly well with a CDK4/6 and hormone therapy, and some of us feel compelled to offer chemotherapy, especially if the surgeon feels that surgery may be offered eventually. So, Dr. Aditi, if you're still there, your thoughts on that, and how do you approach the HER2 negative ERPR positive oligometastatic disease? I think Dr. Garvit, you may have to take that.
So I can completely, especially with the CDK4/6 coming into picture. Now with the abemaciclib coming into picture, it becomes very, very difficult to comment on that. It's a very tricky situation where you are you have recently presented at SABCS, and now obviously was reviewed by Dr. Muzammil in his presentation, where the right choice study, which actually showed that even in visceral crisis, the response to the disease with CDK4/6 inhibitors is so good that it matches with the speed of response with chemotherapy. Now, in this case, if I were to put a patient on curative intent and then not offer chemotherapy, that becomes a very, very difficult situation. As an MDT, I don't know how, a lot of times this discussion, I have it with Dr. Gore also and Dr. Muzammil also when we are having MDTs, that what do you do in such cases? Either, we know that the patient is going to do well for a long, and there's other than, and this is one of the things that I'm pulled up about also a lot of times, and my leg is pulled because of this. I say that there is, with hormone positive disease, there is not just the aggression of, there are certain diseases which are aggressive, but there are certain diseases where there is a tensionality associated with the disease, where it has progressed because of time passage. It is not because the disease itself is aggressive. And I can see you laughing there. But the thing is that in these cases, it becomes all the more difficult whether, to treat. Not giving them curative intent, I think, becomes a little unfair when we know that the data is better with curative intent. Now, if that means giving her chemotherapy where it may not be necessary at all, but then there are a lot of other places also where we make these difficult decisions in favor of chemotherapy, because that's what it is right now. We don't have understanding of the biology of the disease so much where we can, tailor the treatment so much.
Yeah, so let me come quickly to Dr. Aditi before we wind up with the last couple of questions. Your thoughts on this oligometastatic? We've heard Dr. Garvit tell his opinion.
I think as of today, if I have to just sum it up, as of today, there still seems to be a case for surgery for the primarily in oligometastatic subset. And as far as surgery for the metastatic, because of that recent BRG data, when SBRT has not proven to be benefit in the oligometastatic setting, I don't know whether surgery for the metastatic site will also have much role. But still, as of today, with the current data, I agree that curative intent treatment should be offered to patients within the oligometastatic subgroup. Identify patients with good biology and limited burden of metastatic disease, and do offer them surgery for the primary at least.
I think the problem increasingly has been to identify the good biology. And
Right.
what we are clearly seeing is we perhaps are not so good in identifying the good biology, because as we saw in one of the studies that Dr. Muzammil discussed, there were people on the CTC study, the STIC CTC trial. There are people who are apparently supposed to be low risk, so patients who are clinically low risk, but CTC came out to be high and in fact did better on chemotherapy compared to hormone therapy, and therefore, which meant that clinically the patients whom we thought were going to be better and perhaps doing well and may perhaps in an oligometastatic setting may be offered surgery may not be the right choice. Dr. Sachin, yes.
Yeah, Devra, just a small point. So I just want to say that, the time exhibits the biology basically. So once we go into the natural history of the treatment and progress as the case progresses, if the disease remains under control for 1.5 years, 2 years, 2.5 years, and that we continues to see the same 2-3 spots with a low SUV value or maybe non-evade, so that's the time we tackle these spots with some kind of surgery or SBRTs or RFAs. So all those modalities can be used. So let's not jump into the surgery and think quickly in first 6 months or 1 year of the treatment. Maybe delay these decisions. Then we can super select these patients who would be the long-term beneficiaries.
Correct. I think I would perhaps cut down on the the oligometastatic discussion here, because I think otherwise we'll keep on debating and debating. But last two points, and I'll wind up thereafter. Very quickly, Dr. Adwaita, we had the PACE study, palbociclib beyond progression failed to work. We had much smaller maintain study, ribociclib after progression on an alternative CDK4/6 did work for some time, although the PFS benefit was very modest at about 2.5 months, and it was, if I'm right, it's just a phase 2 study. Do we really continue, or is it something that we know will happen? The failure of CDK4/6 beyond progression.
I think it's a field which we are still evolving now. Primarily, I have used CDK4/6 beyond progression in certain situations. Where patient has a oligoprogression, we have always tried to change the hormone partner and continue the CDK4/6. We've seen it work, especially for patients who had a good PFS of say 2 years, 3 years. In them, we know that they do have a different biology. I think, but there is also a clear data which is looking at the newer SERDs, as you rightly put up. There are multiple different trials which have shown that possibly this is an area where these oral SERDs may be beneficial. There are at least 3 or 4 drugs which are currently under trials. Of course, the PIK3 kinase story is also there, in which you would do a PIK3 kinase mutation and then decide whether alpelisib would be a drug of choice. But in terms of even CDK4/6 inhibitor, there are injectable CDK4/6 inhibitors which are coming in, which are much more selective for CDK4, which probably would be the future to look into. But at least as of now, we have 3 of them to work with, and one drug is going to lose patent. So probably from next week, all of us are going to be bombarded with a barrage of palbociclib, which I really don't know how to manage.
But Advait, I would say that abemaciclib may be a better agent to switch and even to carry forward, for a
So abemaciclib definitely has a data in third line, although that data did not include any patients who have been exposed to CDK4/6 inhibitors.
But as a single agent and for resistant disease, this agent is still.
I think we tend to be influenced. I think we tend to be influenced by the pharmacokinetics and to some extent by the adjuvant data for abemaciclib. But I guess it's still an open question. But very quickly back to Dr. Ashish, we had this very interesting.
Devrat, there are 2 questions in the chat box.
Okay, so I'll ask this question and perhaps take up the 2 chat box questions. So Dr. Ashish, the STIC-CTC study, I think the interesting subset is the clinician low and high CTC. But I do suspect that even in a clinician low risk, for a metastatic setting, these days we would offer a CDK4/6 inhibitor along with any hormone therapy. So do you think this is too late, or this is perhaps hypothesis generating, could be taken up for further research in the future?
Yeah, so maybe I don't pay too much attention to that presentation actually. So CTC, are we going to use it as a biomarker to select high-risk patients who continue to be CTC positive and then escalate by adding CDK4/6? And as just looking, you're looking at circulating tumor cells. So at the moment, I don't think that's a very validated. Even to do the test in our situation, I think it's not going to be easy, right? And to especially act on a result, I do not think that's practice changing at all. And maybe that's why I probably did not pay too much attention to that.
I think when it comes to a difficult situation, CTCs may end up helping. As in, when you face a difficult clinical scenario in which you do not know whether the prognosis of the patient and whether you should, let's say you had a disease in which a triple negative, in which the patient has had a few chemotherapies and has recurred after 2.5 years. You want to know what is the role of chemotherapy going forward, how much it will benefit, do you need to give it or not, what is the risk of. So I still think it has that niche role where you are stuck in a difficult situation. It may not be the primary diseasing factor, but it'll just be one other finger pointing towards in your direction.
Fair enough. So I think we're really short of time. I'll take up the two questions. One is, do you think immuno-oncology to addition to fulvestrant without palbociclib is an option? I think the PACE study was one of the first studies that actually looked at that, although this was not the exact combination that we're talking about. I think it's still something that's worth exploring, but not a standard of care. And for most of us, we'll probably not be adding immuno-oncology, any immunotherapy drugs to the hormone therapy at this time. The other question is something I don't understand, TDM1. So I guess I'm not sure what the question was. If Dr. Acharji can ask this question again, we'll take it up. Otherwise, I'll thank all my panelists for the engaging discussion. Dr. Ashish, Dr. Bhuvan, Dr. Sachin, Dr. Advaita, and the two prominent surgical oncologists, Dr. Aditi and Dr. Garvit. And with that, I hand the stage back to the organizers. Thank you very much.
Thank you very much, Dr. Devrat, for having moderated this panel. And because of shortage of time, there were other questions and we wanted to ask, but we're going to move on to the next this thing. And I am going to Dr. Harith requested me to give the takeaway message for this session. And I think the takeaway message, and I'm sure all of you will agree, that biology trumps, and this is what we've been discussing for the last 40 minutes, I guess, that we need to find different ways to understand the biology of breast cancer better. And we've been doing this over the last couple of decades, and maybe coming years will show us better light, and we'll have better molecules which we will treat, which we will use to treat our breast cancer patients, and they will benefit from it. Thank you very much, and we will move on to the next session now. May I invite Dr. Mandar? Sir, could you please start? Dr. Mandar Nadkarni is a consultant at Department of Surgical Oncology in Kokla and Dhirubhai Ambani Hospital, and he's a very renowned breast and GI surgeon. And sir will be introducing and welcoming.
Hi, thank you, all of you. I think it was a great discussion. I've been listening to the talks and the panel discussion, and quite a few new things I've got to hear, especially the viewpoints from everybody. So without spending much more time, is Professor Hyams already on the...
I am.
So we'd like to welcome you, sir. Thank you very much for joining us from San Diego. So we would like to welcome Professor Hyams, who's a director, Desert Surgical Oncology at the Eisenhower Medical Center and medical staff at the University of California Medical Center, San Diego. I guess we are already a bit, ahead, we are lagging behind in time, so I'm not going to spend too much time. So without much ado, we are eagerly waiting for your talk, sir. So I think Garvit is going to start with the case. So Garvit, can I just request you to?
Thank you very much, sir. Could you please, I'll share my slides, or could you please share my slides?
Sure, sir, sure.
Sure, sir, just a minute.
Yep. So while they're putting it up, so I wanted to discuss this case because this case actually shows that how much of a change these genomic analysis of tumor have brought into the management of breast cancer. And if this case was discussed, say, about a couple of years, not couple of, maybe a little more than that, most of us would jump on to starting chemotherapy for this patient. But now what we've been able to do, I'm going to show you in this case, and I'm going to do it very fast because of the shortage of time. Can you put on the next slide, please? No, this is once again. No, I think you have the wrong this thing. Please, can you, I'll share a presentation. Stop sharing your screen. Yeah. So this is a case of a 70-year-old post-hysterectomy lady presented with a right breast lump of 2 months duration, and on examination had a 3 into 3 centimeter mass palpable in the lower inner quadrant of the right breast, and a 1.5 centimeter palpable axillary node. The patient had tubular cup B breast with grade 2 ptosis, and there was no family history of any cancer. When we did a mammogram, it confirmed the clinical findings that there was 2.3 centimeter. There was a tumor at 5 o'clock, which was 2.3 into 1.9 centimeter. Another small hypoechoic lesion, which was about 0.5 centimeter at 7 o'clock. So almost the same quadrant there. The opposite breast was normal. On biopsy, it was proven to have be an invasive ductal carcinoma grade 2 with a strong estrogen and progesterone receptors and a negative HER2/neu. Ki67 for this patient was 35%, and the PET scan did not show any metastatic disease anywhere. These were the mammogram pictures of the patient, and the patient underwent right breast conservation surgery and a sentinel lymph node biopsy. We did it because we'd not done a FNAC prior to planning this patient, and partial breast reconstruction with a thoracoepigastric flap. PT was 2.2 centimeters. The other lesion did not come out to be a malignancy. IDC 3 finally on the final histopath. Again, ER8+, PR8+, and HER2/neu negative. A Ki67 of 35%. Margins were clear. LVE, lymphovascular invasion was and EIC were not seen. Sentinel lymph node biopsy was positive, and hence we did an axillary clearance which showed 3 out of 17 nodes which were positive. And there was an uneventful postoperative wound healing. The pictures on the top are of preoperative, and on the bottom are postoperative. Now, earlier, these patients would generally go for chemotherapy, and now we ended up, because of the RxPoNder trial, we ended up asking for an Oncotype DX, and the patient luckily was affording for the same and had undergone the same. And this was the score which came up. And I think there are no guesses on what we did after that. We started her on endocrine therapy and gave her locoregional radiation therapy. And it's been about a year, so long-term follow-up is still awaited, but she's doing very well. And that was my case. And thank you very much. And let me invite Dr. David Hyams to please start his talk. Thank you, sir, for being here.
Thank you. And I'd like to thank you all for the opportunity. Wish you a pleasant good evening and the opportunity to visit you from California long distance. It is really a great honor to do so. And let me see if I can just get my slides to share here. And there we go. So I trust you can see my slides. So I'd like to again thank you for the opportunity to speak with you this evening. I do need to mention to you as part of my discussion that in terms of conflicts of interest, this presentation is being sponsored by Exact Sciences. I am not an employee of that company and have no stock or ownership interest in the company, although they do provide compensation for the time in preparing this and delivering this presentation. But the presentation itself was developed by me and represents my perspective. It has been reviewed by Exact Sciences for accuracy and content. So moving forward, breast cancer, it's something we're all talking about. It's a disease that we're talking about because of its increasing incidence around the world, but also because of the increasing options that are available, as you discussed in the first hour and a half of this program this evening. However, when we talk about breast cancer, the things that both physicians and patients are interested in is the very simple issue of what's going to happen to them in the future. For many patients, it's the first time that they're facing a direct threat to their life, and that threat or risk is poorly defined. So prognosis is one of the words that comes up, but prediction comes up as well, and these are often interchangeably used. The reality is that there are clear definitions for both of these, and prognosis is generally agreed to be or represent an assessment of outcome that's independent of treatment, and prediction is an assessment of the likelihood of response to a specific treatment. So when we move forward and we think about how breast cancer has been treated and where we're going, we have to look back and see that in many countries, I happen to pick the United States here because I had more data available to me. But if we look at breast cancer mortality statistics from 1975 to 2015, we see a very important inflection point where mortality had been rising until about 1990. And in the US, among virtually all demographic groups, that really started to fall after 1990, which coincided with not only the advent of more screening mammography, but perhaps more importantly, the widespread use of endocrine therapy in the management of breast cancer, as well as cytotoxic chemotherapy. In fact, the US National Cancer Institute at a consensus conference in 2000 stated that adjuvant hormonal therapy should be offered to women whose tumors express hormone receptor protein. But more importantly, and something that seems perhaps even strange today, is that adjuvant polychemotherapy, they felt, should be recommended to the majority of women with localized breast cancer, regardless of nodal, menopausal, or hormone receptor status. And that actually led to a number of trials that looked and derived from a number of trials that looked at polychemotherapy versus control. The Oxford Overview, which I've been pleased to be a member of for many years, looked at some 60 trials in their overview in 2000. 28,000 women made up this population and showed that cytotoxic or polychemotherapy with cytotoxic agents reduced the relative risk of cancer by 23%. That was considered quite significant and quite important and led to the NCI recommendation at the consensus conference. But if we look at this information, admittedly with drugs that predate taxanes, we see that, in fact, about 40% of patients were never going to fail because these patients had disease that was cured by surgery, and about 40% were going to fail regardless of the therapy they received because, in fact, their tumor wasn't going to be responsive to that particular treatment. So in aggregate of the 28,000 women in these trials, perhaps 24,000 didn't need the therapy or weren't going to benefit by it. Of course, the advent of gene expression analysis that became reasonable in cost and reproducible led to the development of a number of companies that have produced commercial assays. I've listed the 6 that have been around, although the one on the bottom right corner has never really launched fully, and that's based on Mitch Dowsett's analysis of estrogen receptor, progesterone receptor, HER2, and Ki67, so-called IHC4. But the other companies are selling assays around the world in various countries to look at better options for prognostic information. And we're going to focus this evening on Oncotype DX, and which is an exact science test, and the MammaPrint test, which is from Agendia. I will very briefly touch on EndoPredict, which is a test popular in Europe, and even more briefly on Prosigna, just because of lack of time. I'll start with MammaPrint because MammaPrint was really the groundbreaker. It was a groundbreaking article by Van de Veer in the New England Journal of Medicine in 2002, in which they took advantage of a convenient sample of frozen annotated tissue at the Netherlands Cancer Institute to pull out some 61 patients that they could use to develop a microarray assay. This was a supervised analysis. The patients were a variety of individuals, relatively younger, 53 years of age or less, Frozen tissue was used. 3/4 of them were ER positive, about half were node negative, half were node positive, about 75% were untreated. And once the assay classifiers were developed and the assay was locked, they then put that group of 61 patients back in the whole pot and use that as a validation set, which is something we wouldn't probably do today in quite the same manner, but things have evolved. And what they were able to show in the New England Journal presentation was the separation of patients with early stage breast cancer into a so-called good signature group and others into a poor signature group with very, very different evident outcomes. And this really opened the door to the concept of thinking about whether or not cytotoxic chemotherapy was really a good thing in women whose overall survival was really good and whose distant recurrence of disease was less than 10% at 10 years. Of course, the test shows or suggests evidence for prognostic value, that is predicting the the outcome of the disease regardless of treatment. But the second assay to come along was the Oncotype DX developed by then Genomic Health. It looked at information from a variety of databases in the United States and tissue archives, including one from the NSABP, where I was the executive medical officer at the time. And they ultimately locked in a proposed assay that would use 21 genes, of which 16 were cancer-related genes, including some of the features that we would not be surprised about when looking at hormone-responsive breast cancer, such as ER/PR, of course, HER2 in addition, and Ki67 in addition to the other genes you see. Of course, as most of you are aware, the Oncotype DX calculates using an algorithm and looking at the gene expression of those 16 cancer genes, a recurrence score, which is a continuous score, and which can be correlated to a specific distant recurrence risk at 10 years. And for convenience, this score and this distant recurrence was divided into 3 basic categories: a low-risk group, an intermediate-risk group, and a high-risk group, as evidenced by the colored bars. The low-risk group approximated that, which was seen in the Vanderveer study. That is a goal of patients with a risk of approximately 10% or less. In the actual validation, it turned out to be a little bit higher. And then the remaining population of higher risk patients with a recurrence score over 18 were considered a higher risk category, which was split into 2 at the median, to either a lower higher risk group known as intermediate, or the true high risk group with a recurrence score over 31. And the initial validation of this population was done in a previously little utilized approach, the so-called prospective retrospective trial, a study in which the study itself was determined in advance, but it used materials that had been collected in a prior study that was organized and managed in a prospective fashion. So it's prospective, retrospective, prospective. And for this, they came to us at the NSABP and used our B14 trial, which looked at hormone-responsive breast cancer in the node-negative population. And these women, we had tissue blocks on 668 of the patients in the parent study, which performed almost identically as those in the parent study. And as you can see, there was about a 15% at 10 years failure rate looking at distant recurrence. But when the assay was applied using the low, intermediate, and high cut points present at the time, you can see that this separated into a group of patients with a 10-year rate of recurrence of only 6.8% for the low-risk group, but as high as 30%, in fact, 30.5% for the high-risk group. And of course, the intermediates sort of fell in the middle, approximately where the parent population was. This suggested with high statistical certainty that the test really provided useful or potentially useful prognostic information. This going forward was then evaluated in a second NSABP trial that we had, the NSABP B20. B20 was a study that looked at the same entry criteria as the B14 trial, but randomized patients to tamoxifen alone versus tamoxifen with a cytotoxic chemotherapy based on a CMF model. And as you can see, this population of patients did show improvement from cytotoxic chemotherapy, modest but real, with a statistically significant p-value of 0.02. When the assay was applied, the low-risk group, perhaps surprisingly, got absolutely no value. And since the low-risk population comprised more than 50% of the patients in the study, this was really important. The intermediate population also got no apparent value from the addition of cytotoxic therapy. In fact, all of the benefit, a 75% reduction in risk, occurred in the high-risk population with a recurrence score over 31. And as a result, this now, for the first time, suggested that this kind of approach could not only provide prognostic information, but true predictive information about how a patient was going to behave when offered chemotherapy, rather than just simply looking at the likelihood of a fixed benefit against a fixed risk. Mitch Dowsett in the UK was provided with an extraction of samples from the ATAC trial performed by then Genomic Health to calculate recurrence score on patients who entered the trial and whose tissues were available. In this particular case, the ATAC trial was conducted only in a postmenopausal population, since it looked at tamoxifen versus versus the use of an aromatase inhibitor, anastrozole. And this trial differed from the prior studies in that it included patients with node-positive disease, separated into 1 to 3 positive nodes and those with 4 or more positive nodes. And in fact, as you see here, going across the x-axis, with the increase in recurrence score, there is an increase in the 9-year risk of distant recurrence. What I think is interesting among this is that not only is this seen in the node-negative population, it's seen in all of the populations, but there are 2 points that stand out. One, for patients with more than 4 nodes or 4 or more nodes, even a low recurrence score starts with a pretty reasonable risk of distant recurrence. But perhaps as interesting or more interesting is that patients with 1 to 3 positive nodes and patients who are node negative have overlapping confidence intervals for recurrence scores in what was then considered the low risk group, up to a recurrence score of 18. And there is no appreciable difference between these individuals despite having up to 3 positive nodes, as did the patient that was presented at the beginning of this portion of your meeting this evening. This provides important prognostic information that may be helpful in how we think about patients, but not yet predictive information about response to chemotherapy in this population. But the population of node-positive patients did have an opportunity to participate in a chemotherapy trial against no chemotherapy in the Southwest Oncology Group Trial 8814. In this particular study, patients were offered the opportunity, if they were postmenopausal, of receiving tamoxifen alone or tamoxifen with a CAF cytotoxic therapy option. And when you look at the responsive patients by, again, the recurrence score groups, low, intermediate, or high, you see once again, as in the earlier NSABP trial, all of the benefit was confined to those who had a recurrence score of 31 or above. Again, providing, for the first time in the node-positive population, important predictive information as well. Of course, while this was very compelling, and while there were many, including Simon at the U.S. National Cancer Institute as head of bioinformatics and statistics, while the prospective retrospective trial, particularly if validated in several iterations, was considered level 1 evidence, it had the diminutive of being level 1B evidence, with the best evidence still reserved for the true prospective trial. This led the U.S. National Cancer Institute to set aside over $100 million to conduct a trial, TAILOR-X, which was conducted from April 2006 to July 2018, and which randomized 10,000 patients. In Europe, the EORTC sponsored a trial known as MIND-ACT, which looked at the MammaPrint assay and enrolled 6,600 patients from 2006 to 2016. There was a trial in Germany that was converted into a prospective trial to look at the Oncotype assay with 3,000 patients. And finally, there was a second trial funded by the U.S. National Cancer Institute, the Responder trial, which accrued from January 2011, reported in February 2021, in which 5,000 patients were randomized. If we look at the TAILOR-X trial, the basic schema of this trial was to look at potentially eligible patients, of which ultimately 10,000 were registered, and were to perform the Oncotype DX assay. If the recurrence score was considered low, which for this particular study was adjusted to be a recurrence score of 0 to 10, they received endocrine therapy only. The cut point between low, intermediate, and high risk changed for this assay for a number of reasons we don't have time to go into this evening. But since those separations into risk categories were absolutely and completely arbitrary and were really done for the convenience of analysis in the initial studies, there's no reason that one can't do this. And in fact, the mid-range now consisted of 11 to 25, and a high-risk group consisted of 26 to 100 for recurrence score. Those in high risk all received endocrine therapy and chemotherapy, and the study really focuses on this mid-range with a recurrence score of 11 to 25, which covers a good portion of what was the intermediate risk score of 18 to 31, and randomize those patients to receive either endocrine therapy alone or endocrine therapy with cytotoxic therapy, or followed by cytotoxic therapy. We're going to focus on the low-risk group to begin with, that is those with a recurrence score that was under 11. And what we can see is, looking at the study-defined primary endpoint, or distant recurrence-free interval, that the 5-year DRFI was 99.3%. The 9-year second report was 96.8%, almost 97%. If we look at other measures of outcome, including the recurrence-free interval, that was 98 and 95% respectively for time, and even the overall survival rate very high at 98% and almost 94%. You may note that the disease-free survival rate was a little bit lower at 5 years, 94%, and at 9 years, 84%, but that's because disease-free survival captures other events from other tumors, including contralateral breast cancer, which actually exceeded the rate of distant recurrence or ipsilateral local recurrence for this population of patients, and which is what pushed down that number. This provided important prognostic information. We don't need prediction when you have a 98 or 99% distant recurrence-free interval, because those patients are going to do very well. And there isn't anybody who would be inclined to utilize cytotoxic therapy for these individuals. But what about this new intermediate population where the randomization took place? Well, that required more time, 10 years of follow-up, because the event rate was actually lower than anticipated. But in fact, the two curves, whether chemotherapy with endocrine therapy was utilized or endocrine therapy alone, essentially completely overlap. And this provides very, very useful predictive information, because it suggests for this entire group of patients that there is no value in utilizing cytotoxic therapy if a recurrence score is 25 or less. If we add all of these arms up on one slide, what we can see is that arm A, which was the lowest risk group with endocrine therapy alone had a 3% distant recurrence rate. Arms B and C, which comprised the recurrence score 11 to 25, had only a 5% distant recurrence rate together. And Arm D, which received chemoendocrine therapy, had, with a recurrence score of 26 to 100, had a 13%, yes, distant recurrence rate. And I think this is really quite important because I'd like to remind you that in the B14 validation study, that the recurrence rate for high-risk individuals was around 30%. So this represents a significant decrease by focusing in on a population of risk and giving drug therapy to that population. This provided both important prognostic and predictive information. So, again, the primary endpoint for a recurrence score of 0 to 25, no chemotherapy benefit, 26 to 100, there is chemotherapy benefit and it should be considered. Now, the reality is this study did not provide prospective detailed information on the group of patients with a recurrence score of 26 to 31. That is estimated by a reanalysis that was done of the B14 and the B20, trial after the fact. And so we really don't know what happens between a recurrence score of 26 to a recurrence score of 31. We assume that these patients get some benefit, particularly as those numbers get higher. But this is a population in which individualization of treatment still is a reasonable thing to do. But I'd like to move on to another feature that came out in this particular study beyond this predictive information, which I've shown you. And that took place in an analysis based on age and recurrence score subgroup. For patients over the age of 50, whether you looked at recurrence score broken into little groups 0 to 10, 11 to 15, 16 to 20, 21 to 25, none of these had chemotherapy benefit. Recurrence score 26 to 100, these had a large chemotherapy benefit. And thus, that is useful because 15% of patients only greater than 50 years of age have a recurrence score 26 to 100. This means that 85% of patients, at least based on the US population database, can avoid cytotoxic chemotherapy if they're postmenopausal. However, an interesting surprise, perhaps, was looking at a population of patients who were premenopausal. This population, when one looked at the breakout in scores from 0 to 10 and 11 to 15, again showed no chemotherapy benefit. But the exploratory analysis for a recurrence score of 16 to 20 showed that there was actually a statistically significant benefit of only 1.6% for this population, and then a greater one of 6.5% for the population with a recurrence score of 21 to 25. And this was a bit confounding. How could this be? And why might this be? The 1.6% advantage was only possible with statistical significance because the study population was so large that even a very, very small difference could show up. One could wonder whether or not this difference was enough to really justify cytotoxic therapy, because there's a difference between statistical significance and clinical value. The 6.5% number, though, does raise one's eyebrows and makes one wonder whether treatment should be utilized. However, around the same time or just before this study information came out, data from a large trial in the US, the SOFT trial, showed that there was in fact a similar decrease in recurrence in patients who had hormone-responsive breast cancer who were treated with ovarian suppression. And that ovarian suppression value, in addition to primary endocrine therapy with either tamoxifen or an aromatase inhibitor, was of a magnitude very similar to that seen in the amalgamation of patients with recurrence scores 16 to 25. And so it remained uncertain whether or not this was a blip whether this represented true chemotherapy benefit or whether it represented a benefit because chemotherapy effectively took a sizable population of these patients and put them into menopause by effectively using a toxic form of ovarian suppression. Nonetheless, this is important predictive information, which needs to be discussed and considered in the management of these patients. So this brings us to the last of these trials, the responder trial. And the responder trial had a different focus. It was designed to focus on patients who were node positive, because as you recall, TAILORx was all node negative patients. And in this particular trial, the key portion was to take node positive patients and one with 1 to 3 nodes and randomize them after an Oncotype recurrence score to either endocrine therapy alone or chemoendocrine therapy. These individuals were felt to be of sufficiently low risk based on prognostic information from previous studies to justify the randomization. And in fact, the outcome with 5.3 years of median follow-up reported by Kalinsky in the New England Journal of Medicine in 2021 showed a statistically significant advantage with a 5-year invasive disease-free survival absolute difference that was small, but again, because of the large population, significant of 1.2%. Excuse me, that was not significant, of 1.2%. So this study, although there was a difference, it did not show a difference that was meaningful. But when one went, and thus cytotoxic chemotherapy in this population of patients is really not indicated. However, the question arises, what happens in a population of patients who are premenopausal versus postmenopausal? And what we see looking at the postmenopausal patients is a true overlap of the outcome figures, as we saw in the overall population for TAILORx. But once again, this separation that occurs in premenopausal patients with a recurrence score of 0 to 25. And that was, in fact, significant. This, again, provides important predictive information because this now has to be considered in recommendation of drug therapy for this population. Now, in the example that was provided in the case study at the outset of this session, that patient was postmenopausal, so it's absolutely reasonable and appropriate that she would receive no cytotoxic therapy. But had her age been 40 instead of 70, then a different issue would be at hand. If we look over all of the information available for these populations of patients, we see that the majority of hormone receptor positive, HER2 negative early breast cancer patients can be spared chemotherapy when decisions are guided with gene expression profiling using the 21 gene assay. We see for patients who are greater than 50 years of age, whether they're node negative or have N1 disease, there's no apparent chemotherapy benefit for a recurrence score up to 25, and then increasing chemotherapy benefit for those patients whose recurrence score is 26 and beyond. For patients who are less than 50 years of age, there's no chemotherapy benefit for low recurrence scores, but there appears to be some chemotherapy benefit, although quite small, for recurrence scores that are above 16. Whether or not this is a direct cytotoxic benefit or whether the benefit is due to ovarian suppression remains uncertain. For patients who have N1 disease, again, we see in the premenopausal population a benefit which is somewhat more consistent and less variability that starts at the lowest recurrence score of 0 to 10, and that runs in the range of 2 to 3%. But again, quite a small benefit, and one that has to be taken into account on a clinical significance level in talking to patients and considering whether ovarian suppression might be utilized as an alternative to chemotherapy, depending upon a patient's status, wishes, and other issues. This, again, is important predictive information. So now we move on to the MINDAC trial, which is the study looking at the MammaPrint assay. And you can see here that there was a large population of patients that were screened, but ultimately 6,800 patients entered this study. And the basis of this was a little bit different. Patients were assessed using clinical risk with a nomogram called Adjuvant Online that is no longer available, but there are other nomograms like this, and a genomic risk assessment that was done using the 70-gene MammaPrint assay. When there was when both of the assays or approaches agreed, the Adjuvant Online, the nomogram, and the genomic risk, with clinical risk low and genomic risk low, these patients were not recommended for chemotherapy, endocrine therapy alone. For patients who had concordant high clinical nomogram risk and high genomic risk, these patients were recommended to have chemotherapy and endocrine therapy. And the study really focused on the discordant population who either had low clinical risk but high genomic risk, or high clinical risk but low genomic risk. And this population of patients were evaluated in two ways. First, the clinical high-risk patients in the orange box and the genomic low-risk patients in that box were assessed for the likelihood of distant recurrence. And we'll get to that in a moment. That was the primary endpoint. And if they met a certain threshold, the assay would be considered prognostic as a good risk population based on the genomic low risk assessment, even though they had a clinical high risk going in. The second way in which these populations were utilized was to combine them and randomize chemotherapy in addition to endocrine therapy to see whether or not the assay had predictive value. Unfortunately, the population was sufficiently small and the magnitude of any difference was so negligible that there was no evidence of predictive value from this test in terms of outcome when we talk about the randomization. So I'll dismiss that quickly. When we look at this population for prognostic information, what we see, I'm going to go back just for a moment, because there's one other point I want to mention here. When this study was done, I think this is very important, a quality control issue arose. The quality control issue was not appreciated for 6 months, and thus 162 patients who were identified as high risk were reclassified when this issue was identified and solved, were reclassified as low risk. And I bring this out not to criticize those doing the study or the assay itself, but to point out that this happened because the company that ran the assay decided to change one reagent, not even in the actual assay, but in the isolation of RNA. And it shows you that even the tiniest change, even though you're using this RNase, but you change to a different brand, unless you're very, very careful and you can prove that this has no impact, can really make a tremendous difference in outcome. And I think this is very, very important to remember, particularly as laboratories pop up around the world that do imitation assays of MammaPrint or imitation assays of Oncotype. You can't be certain just because they're using the same genes and they're using similar techniques that the outcomes will in fact be the same. So moving forward, the primary endpoint of the MINDAC study was to exceed a null hypothesis, which was set at 92%. The null hypothesis was such that the confidence intervals had to be greater than 92% for distant recurrence-free, distant metastasis-free survival for the assay to be proven to be prognostic. And in fact, it was. The distant metastasis-free survival for the primary test population with clinical high risk but genomic low risk was 94.7%. And as you can see, the lower confidence interval exceeded 92% by 0.7. This provides prognostic information for this unique population of clinically high risk, genomically low risk patient using the MammaPrint assay. It does not, as I said before, provide any predictive information. In the New England Journal of Medicine publication of Cardozo, looking at distant metastasis-free survival using a genomic versus a clinical risk assessment strategy, in fact, there was no difference in outcome overall. So the question is the assay predictive overall? And the problem is that we just don't really know because of the unique design features of this particular assay. With a follow-up of nearly 9 years, an additional publication took place in the Journal of Clinical Oncology, and it was thought that the group of patients overall that were in this study did generally well with an excellent prognosis, except for the group of patients who had concordant clinical high and genomically high risk. But when we really start to look closely, did they really do that well? In fact, the clinically high and genomically high risk don't do so well. And this population continues to decrease and is a far cry from the 97 or 98 or 99% outcome that we saw in the low risk population in the TAILOR-X study that I presented to you earlier. So the other information that we don't have is predictive information. One of the questions we might ask is for clinically low risk, genomically low risk patients who receive endocrine therapy only, is this enough? There's no predictive information. The answer probably is pretty close to yes. These numbers look very good, but not as good as we might like, but it's unlikely that anyone is going to offer cytotoxic therapy in that setting. For clinically high and genomically low, and clinically low and genomically high, that is the discordant category, these numbers are now drifting down, and I think approaching a level in which individuals might want to consider treatment beyond simple endocrine therapy if they knew that there was going to be predictive information that would provide utility. And the final question is do all of these patients benefit from cytotoxic therapy, or are there those among these who will do reasonably well without it, or who in fact would get no benefit by it? We again don't have that information because we don't have predictive information in this population. So one of the things, however, that is interesting of this study was that if you looked at the whole group of patients who either did or didn't receive cytotoxic therapy, forgetting about gene assays, what you notice is the population of patients who were over 50 years of age had no difference between their outcome curves, whereas those patients who were under 50 years of age actually did have a separation in their outcome curves that was about 5%, mirroring what we saw both in TAILOR-X and in the responder trial about chemotherapy in premenopausal patients. So the MINDACT assay is prognostic in the clinically high-risk, genomically low-risk population of patients, but that is the only group in which you can use that information reliably. So it is not predictive of who will respond to chemotherapy for any other subgroup and hasn't been proven as prognostic for the other subgroups. And therefore, I think the assay has some limitation. Fine if you end up in this category, but not necessarily fine if you don't. I'm going to touch for a second, even though I said I wouldn't, on EndoPredict, only because I'm going to use this as an example in comparison. EndoPredict is an assay that is popular in Europe, developed in Germany. It's based on 12 genes, 8 of which are cancer genes. It uses an algorithm to produce a continuous score. Clinical information can be added to that score to improve its precision. And that's all I'm going to say at the moment, other than to say that it does have some validation data for prognosis without any predictive information using prospective retrospective trials. However, when one looks at a comparison of different assays, just because we can separate patients, as EndoPredict does, into low, intermediate, and high-risk populations that appear to mirror, in terms of percentage distant metastasis-free survival, the recurrence score categories, it doesn't mean they're the same. In this study conducted by the TransAttack group and initially by Mitch Dowsett and analyzed by Booz in the Journal of the National Cancer Institute, you see the EndoPredict score and the recurrence score low risk is very similar, and the EndoPredict high score and recurrence score non-low risk, which includes the old high-risk category of over 31 and the entire intermediate group of 18 to 30, you see that even with that broad definition, recurrence score identified 50% more low-risk patients than did EndoPredict. And that means that there are a lot more of these patients who are going to be receiving cytotoxic therapy. The patients aren't the same. And we have no predictive information to even know how those high-risk patients are going to perform, or whether the low-risk patients with EndoPredict represent the same population of individuals that are low risk with recurrence score and that they will not benefit from drug therapy. An example of this is a head-to-head comparison that was conducted by Shivers of Mamaprint and Oncotype. And what you can see here in this scattered graph is that patients classified as high risk by Mamaprint, 33% of these would have been classified as low risk by Oncotype, and actually patients who would not benefit from the cytotoxic therapy that is recommended for high risk Mamaprint patients. Conversely, of the patients classified as low risk by Mamaprint, 5.6% were classified as high risk by Oncotype and wouldn't receive potentially life-saving therapy that they would receive if they had the gene expression assay performed as Oncotype DX. Perhaps another way of looking at a couple of assays all in the same study, conducted the proper way, not by simulations of the other assays, but actually where all of the assays were conducted by the commercial labs that actually sell and market the assays, were in the preliminary form of the Optima study, in which Oncotype, a different assay looking at 50 genes developed by Chuck Peru and his group, Prosigna, or the Mamaprint assay, were all compared head-to-head. And what you can see here again is, if nothing else, just looking at prognosis, Oncotype put vastly more patients into a low-risk population that we know doesn't benefit from cytotoxic therapy. With a recurrence score of 0 to 25, 82% of the population in the Optima trial fell into the low-risk population, with only 18% in the high risk, in which chemotherapy would be recommended for the majority, if not all, of those patients. Prosigna, high risk, now 34%. So twice as many patients would be receiving chemotherapy in this population if Prosigna was done. And if Mamaprint were done, it would even be higher, nearly 40% of patients. So assays are different. And this is even without real predictive information from any of the other assays. In fact, if we look across all of those marketed assays that I showed you, and the populations in which there's data, whether we're talking about premenopausal, postmenopausal, node negative, node positive, all of the boxes are ticked, including prognostic and predictive information for the Oncotype tests with more than 20,000 patients that have been evaluated. In the case of Mamaprint, the only other assay to be subjected to a true prospective analysis, the assay is validated in premenopausal, postmenopausal, node negative, node positive were included in MIND-ACT, and does provide prognostic information for a unique population of patients, the clinically high-risk patients by adjuvant online or an equivalent algorithm, presumably, but no predictive information and no information about the other subgroups that were in Mamaprint. Prosigna, EndoPredict, all of these fail in terms of providing predictive information, and for Prosigna and EndoPredict, very little information for the premenopausal populations. As a result, the Oncotype DX has been incorporated, the 21 gene assay, into the National Comprehensive Cancer Network guidelines for breast cancer for 2022, in which for patients who are postmenopausal, whether they have node negative disease or N1MI or N1 disease, all of them should consider strongly the 21 gene assay. If the recurrence score is 25 or less, adjuvant endocrine therapy should be utilized. For recurrence score over 26, chemotherapy should be considered or utilized. And then for patients with N2 disease, we don't have information, and thus cytotoxic therapy is still recommended, although we really don't know whether this population of patients actually benefit or whether we're doing it because we're just concerned and it's the best option out there. For patients who are premenopausal, these individuals, if their tumors are very small, adjuvant endocrine therapy alone should be adequate. For patients whose tumors are more than half a centimeter, they recommend that if they have node negative disease, that the assay be strongly considered. If the recurrence score is high, clearly cytotoxic therapy should be utilized. If the recurrence score is less than 15, endocrine therapy alone or endocrine therapy with suppression could be chosen. And for those 16 to 25, endocrine therapy with ovarian suppression or ablation or adjuvant chemotherapy with endocrine therapy could be considered after discussion with the patient. For those patients who are premenopausal with node-positive disease, again, for individuals who are not a candidate for therapy, they can have endocrine therapy. For those patients who are candidates, they could have gene expression assay to assess prognosis. And I believe, a personal opinion, to discuss the relevant value of the cytotoxic therapy for those patients with low recurrence scores, because a 2% advantage may or may not be meaningful to all patients in the same way. And certainly ovarian suppression becomes an option as well in this population of individuals. I will not go through the ASCO guidelines in detail because it's a little bit harder to read, but they essentially say the same thing. They include other assays that may be utilized for prognosis, some of which are not available at all, like UPA and PAI. But nonetheless, I leave that for you to review. But all of them indicate the utility in the same way we've just discussed of the 21 gene assay based on the prospective information and secondarily MammaPrint for prognostic information in the population in which it is a candidate. We've come a long way over the 30 years since about 1990, when we had this inflection point we discussed at the beginning of our discussion. And we've made a lot of progress. We've come to be able to talk to our patients in personalized and individualized care in a way and a precision that has never been possible before. And with the advent of coming assays that look at circulating tumor DNA and look at minimal residual disease, we hope to go even further in the future. But we don't want to step backward, and using the tools we have in the most efficient and judicious way is a means to avoid that. I'd like to thank you for the opportunity to speak with you this evening, and appreciate very much. I hope I'll have an opportunity in the future to perhaps meet some of you personally and discuss this further.
Thank you very much, sir. And that was really an enlightening talk, and it was a good amalgamation of all the genomic analysis and how they've developed, and all the data very well presented. And without wasting much time, we will move on to the panel discussion, where I will invite you also to be a panelist, so that Dr. Advait, who's an associate director at Nanavati Max of Medical Oncology at Nanavati Max Institute of Cancer Care, he'll be moderating the panel. And in the other panelist, I will invite Dr. Bhuvan Chugh, who is a senior consultant in medical oncology at Max Delhi, Dr. Aditi Chaturvedi, who is a senior consultant in surgical oncology, breast in Max Delhi. And I would also like to invite Dr. Rima Pathak, who is an associate professor in Department of Radiation Oncology at Tata Memorial Hospital, which is a part of Homi Bhabha National Institute. With this, without wasting much time, may I invite Dr. Advait Gore to please take from here. And if there are any questions that we need to ask, sir, that can be asked within the panel discussion. And I would request Dr. Gore to please keep the panel as short as possible, because we are really running late, and it's late Friday night here.
Yes, Garvit. I think we've heard an excellent talk from Professor David about how the development of these assays and how clinically useful are these. We've also seen that a lot has changed since these assays have come. We've got newer treatment options. We've had the advent of ovarian function suppression, adding on to the confusion in terms of benefit of chemo versus ovarian suppression, the extended adjuvant therapy with the CTS-5 scoring. But still, we know that there is an unmet need in patients with hormone receptor positive patients who do have some primary resistance. And we've also seen in the last couple of years the inclusion of novel therapies like PARP inhibitors in adjuvant setting, and also the monarchy data looking at the adjuvant CDK4/6 inhibitors to be used in treatment of hormone receptor positive HER2 negative breast cancer. Professor showed us this slide about utility of multiple biomarkers. These are essentially looking at genomic testing, where Oncotype and MammaPrint are the main main test which we follow. So I'm going to go with a case. This is a 61-year-old female who noted a left breast lump since about 2 months. Clinically operable disease. She underwent a left breast conserving surgery and a sentinel node biopsy. This was done in January of 2021. The histopathology showed an IDC grade 3 with 2 centimeter tumor, no lymphovascular or neural invasion, margins were free, and it was T1C N0 with a strong ER/PR positive status, Ki67 30%, and HER2 negative. There was a family history of CA lung in elder sister, CA pancreas in second sibling, and RCC in an elder brother. I would start with Bhuvan. Bhuvan, any further tests for further decision making in this scenario?
The size of the tumor is 2 centimeters, right? And it's a grade
2
3.
centimeters, yes. How would you approach this if this patient was in your OPD?
So she's a 61-year-old female who has a clinically high-risk tumor. She is a luminal B. So either she undergoes, with the surgery only, she probably will have a 10-year survival of around 68 to 70%. Adding hormone therapy to it will add another 5 to 6% to it, and chemotherapy will add another 4.5%. So if she understands that, and if she understands that, I probably would advise her 4TC. And otherwise, if she's a little apprehensive about it, I probably would have to go for a gene prognostic assay. I generally prefer a Oncotype DX, because I probably it's just the habit of it. I've had depth into it, so I'm most comfortable with that.
Bhuvan, you must have come across certain IHC-based predictive markers. What is your opinion about them? There are few which are being marketed in our country.
So I generally don't. I think this is what is good enough for me. If you look at the NEJM paper which was published subsequently to the TAILORx data, so I generally end up doing the clinical pathological risk assessment or a genotypic risk assessment. I probably have not had experience with the IHC markers there.
Sure. Garvit, I'm dragging you also into this. Any thoughts on this?
With a Ki67 of 30% and a 2 centimeter tumor, which is T1C, I am I'm sorry, I missed the age of the patient, 61 years.
She's
Sorry.
61. She's 61.
She's postmenopausal. I think I would just, as per
Yes.
current NCCN guidelines, I would ask for a genomic analysis to go ahead and decide on what is the next, provided she's able to afford it. If not, I think I will go with what Bhuvan said, that I would end up giving her a little bit of, advising her on a little bit of chemotherapy, not a little bit as in 4 TC to be precise, and then see further what goes on.
Sure. Dr. Aditi, your experience about these IHC-based predictive markers which are currently in use?
So I think we have limited experience as well. Bhuvan and I work in the same center, and we are not using the IHC-based predictive markers very frequently. Very rarely, with proper counseling, if patients cannot afford and they want to avoid chemotherapy, we give it with the caveat that we don't have enough evidence.
Sure, sure. So this patient actually underwent an Oncotype DX testing, and the score came in as 30. Aditi, what would you do? Go ahead with chemo?
Yeah. Go ahead with chemo, yes. Go ahead with chemo. Refer it back to a medical oncologist.
Bhuvan, I think you already had expressed your this thing. So we've seen the Taylor RX data looking at endocrine therapy and chemo, and it is very clear that at least in node-negative patients, the data clearly showed that if patients have a recurrence score of 25 or less, and if patient is more than 50 years, they don't have any chemo benefit. Patients who are less than 50 years of age and a recurrence score between 16 to 25 may derive a benefit from chemo. However, it was unclear whether what to do in terms of lymph node positive patients. So now the second case, this has been a 52-year-old lady with a right breast lump, which was incidentally detected on a screening mammography. And she underwent a biopsy confirmed malignancy, and subsequently underwent a right breast conserving surgery with sentinel node. But there was an axillary clearance also, which was done as the node came positive. The final histopath showed an invasive duct carcinoma grade 3 with a 2 centimeter tumor, LVI-PNI negative, margins were free. There was 2 lymph nodes which were positive out of 14, no extranodal spread. Again, strong ER positive, strong PR positive with a Ki67 of 45%, HER2 negative. No contributory family history. Garvit, you would again send this patient for an oncotype, or you would straight away start off with treatment? This is a borderline scenario with age being 52.
You know, I will take the easier route. I'm going to send the patient across to your room. But so I would, you know, frankly speaking, on a 52-year-old woman and with a Ki67 of 45%, I would be more inclined towards asking, requesting her to think about chemo more strongly rather than going for any genomic analysis, because if we're not looking, if you look at the MammaPrint data, this is clinically high risk.
High risk.
I mean, there is, it's confusing. If it would be confusing if she came as genomic low risk, but I would prefer giving her chemotherapy. She's young, she's high risk in terms of Ki67, she's node positive. I don't think there's a question there.
Professor David, what would you do in your practice? Sir, you're on mute. You need to unmute yourself.
Yes. So thank you. In my practice, I would do gene expression profiling. First, I think MammaPrint and the data from MindAct show, I mean, the very basis of MindAct is that there is a sizable population of patients who, despite what we think clinically as being high risk, turn out to be low risk. And using that assay in that unique population of individuals, you identify people who have a good outcome in the 90s in terms of distant metastasis-free survival. And it's really a shame to give those individuals cytotoxic therapy if their risk is sufficiently low that they're not going to benefit. And while we tend to be more excited about giving younger women in general aggressive therapy. These are also the people who are going to have a long life ahead of them, hopefully, in which the downstream sequelae of such therapy are going to potentially manifest. The long-term effects of the drugs that are utilized. I, of course, would use Oncotype, which is more widely used in the US, and I would use it because not only does it give me information about her true prognosis, but it gives me information about her likely benefit. You've listed her age at 52, but I don't think I heard if she was technically menopausal or not, but she's certainly probably perimenopausal. And many women at 52 are in fact menopausal and would benefit by cytotoxic therapy. And even if you believe that she is on the verge of menopause, again, a 2% difference in outcome is really a very, very small one. And I think you have to have that discussion with patients with real data and say, this is it. What do you think? How important is this to you? And an option obviously would be to kick her into menopause if she is perimenopausal with ovarian suppression, which would be a very, very reasonable treatment for such an individual to avoid cytotoxic therapy.
Sure. So she did undergo Oncotype DX testing and turned out to have a low risk disease. Now, in this scenario, the issue is now we see that the adjuvant abemaciclib data that the patients who were within 16 months from their surgery.
Sorry, Dr. What was she premenopausal or postmenopausal?
She was perimenopausal.
No, the thing is, as per the RX founder, how did you decide to go with the Oncotype in that case?
So basically, she was a perimenopausal. It was almost 6 months back that she had her last menses, and that was the main.
So by definition, she becomes a premenopausal. So by definition,
she doesn't become postmenopausal. By definition, she becomes premenopausal, and that's the reason why we decided that we should be looking at offering her this option for treatment. Because single node disease, we know that Ki67 was high, but very strong ERPR positivity. Those were the main factors by which we decided to go in for an Oncotype. And now,
hi, I just have a question here. I'm Reema here.
Yeah.
So just looks like very clearly that Ki67 is not something that anyone is basing their decision on.
Yes.
So
that is definitely one of them.
Which is quite counterintuitive, because that's exactly what we do in TMH. Obviously, that is the way to try and super select our patients, but we heavily base our decisions on Ki67 to even offer Oncotype DX, because not everyone can afford it in our setting. But it so looks like that in real life or in ideal setting, Ki67 is not something that anyone bases their decision on. It's just
I don't completely agree. So I don't completely agree with that.
There are issues regarding the Ki67 reporting also itself. There is
yes,
an issue regarding using the cutoff everywhere, whether 10%, 20%. That debate always goes on. But I think more or less, if you are in a good center where you have a good facility to get a Ki67 done, it is reliable with a good pathologist. However, there is another big issue which we face outside academic institutes, is that the patient themselves come reading about these tests and they come and ask for it. That has been another issue which is faced by many of us, where patients would come and ask saying, oh, we've read about this test that I can avoid chemo. Do you feel I should go in for that? And then the difficult part starts about trying to explain, and many of them don't want to accept that there is that they shouldn't be undergoing this test. That also is another problem at times. Have any one of you faced this in practice?
So I think, coming back to what Dr. Reema said, when you have a KI, and I think KI goes in accordance with the history. So somebody has a longest standing tumor, has a history of year, has a KI of 8 to 10%, you may choose not to give therapy. But when you have a KI more than 20%, I think its relevance to choose chemotherapy becomes a little difficult. So let's say a patient has a 3 to 4 months history of a tumor, and then it has a KI of 20-25%. I think beyond that, that's where the Oncotype DX or a gene prognostic assay comes into the picture, because these are the patients you're trying to figure out the subset which are genomically low risk. So we are all probably able to figure out the patients who are low risk by the KI. Somebody has an 8 to 10% KI probably will be low risk. So I think coming back to what you just asked, I think yes, there is a fair point. Most of the time when the patient comes to us, they do have a fair idea of having these gene prognostic assays and how they can avoid the chemotherapy, and the cost is not an issue. So I think yes, we are talking about two different clinical settings between TMH and private sector.
Yes. Professor David, any comments about the KI?
I would like to make a comment. I think that Ki-67 is a very challenging test. It's challenging because of all of the tests that we do, it has consistently had the most variability between institutions and even within individual laboratories, unless they are extraordinarily rigorous. And I'm speaking for the US, I can't speak for India. The reliability and reproducibility of Ki-67 has been very poor. In fact, it was so poor that it led ASCO and the American College of Pathology to try to issue guidelines to standardize Ki-67 conduct, and they have not met with great success. So in many institutions, Ki-67 isn't even reported in the US as a primary report in terms of markers. And I think it's a bit dangerous to utilize it as a decision point, using at least the genomic measurement of Ki-67 in concert with, which is what Oncotype does, in concert with a variety of other markers, may be more valuable. But and I recognize there are issues of affordability. The question is what's best, and then what can we do for a patient who can or can't afford something.
Sure.
So if I can just weigh in a little bit here, I am in a unique position here where I've just, very recently moved from an academic institute, which is Tata Hospital, to a private setup. But this is what I felt, and I very strongly believe that Ki-67 was something that we could follow. In fact, we published or in fact presented in international conferences where we looked at our data and looked at Ki-67 and tried to find out how many people were actually eligible for Oncotype DX in a year. So that data was about, I think it's been presented in a conference, as not yet published, but it was about 7% of patients only were able, were eligible for Oncotype DX. Forget about and this is what I'm talking about: ERPR positive, node negative patients who are postmenopausal in this thing. So only 7% were eligible for Oncotype DX in that setting. Now that I move into a setting which is a private setup, now Ki-67 suddenly becomes a very difficult test for me to analyze when I see a report. I have to see where the report is coming from. I have to see how, like Bhuvan suggested, how long the tumor has been there. That tensionality of time is a very, very important thing that plays on my mind when I'm looking at a report. And when I look at the history, if the tensionality suggests that it has been a long-standing tumor and Ki-67 is concordant and it is low risk, and the patient is absolutely on the borderline of affordability, where if I ask her to spend the money in Oncotype DX, she may not be able to afford chemotherapy, then in that case, I don't ask for an Oncotype DX. Otherwise, or any genomic analysis for that matter. Otherwise, I just request the patient to go ahead with chemotherapy.
Sure. Thank you, Garvit. I think when we look at these multiple biomarkers to guide adjuvant decision making, Professor mentioned in his talk about the 21 gene signature in node negative as well as in 1 to 3 node positive with the Taylor RX as well as RxPonder data, that they both are prognostic as well as predictive. Other tests are still looking into the predictive part. They do have a good prognostic implication. My last case here is a 42-year-old premenopausal lady, a right breast lump detected 3 months back, right mastectomy and axillary clearance was done. And this was a large tumor, which was 5.4 centimeters, grade 3 disease, LVI positive, margins were free, T3N2 disease, and there was no extranodal invasion. Again, ERPR positive, very high Ki 67. She's received adjuvant chemo with 4EC followed by docetaxel, and she's currently on ovarian function suppression and AIs, and has completed adjuvant radiation. So, Dr. Reema, any further workup that you still feel is necessary that for further treatment decision making now that there are other options which are available?
So in terms of other options, in terms of CDK4/6 inhibitors or something like that, is what you're pointing at?
Yeah.
So
When would you ask for a BRCA testing, or when would you look at adjuvant abemaciclib?
So for a 42-year-old who is otherwise ERPR strongly positive and without a family history, I don't think I would really weigh in on BRCA testing unless the patient is very keen, at least in our setting. However, if the patient has a family history, or for that matter is anxious and wants to know about her genetic risk, then in that case, go ahead. And I would strongly suggest that perform a multi-gene NGS panel test rather than just do BRCA test, because there is more than BRCA that patients have. And now with newer guidelines, more of these genetic mutations are becoming actionable. So don't restrict just getting BRCA 1 and 2, unless we are in metastatic setting and just looking for therapeutic options.
Yeah. Aditi, any inputs?
No, I think, adjuvant abemaciclib should be considered. I think genetic testing, I would offer to this patient. BRCA testing, I would offer to this patient, considering that she is 42, even if it's hormone positive breast cancer. Well, obviously after appropriate counseling, but I would definitely consider genetic counseling and testing for her, and offer adjuvant abemaciclib. BRCA, if BRCA is positive, then other options will also open up.
Bhuvan, have you started offering adjuvant abemaciclib to all patients who fit the
Yes.
inclusion criteria?
So I don't follow the KI criteria. I kind of follow the 4 nodes criteria.
Yeah. Yes.
So that's where I go through it. And I think me and Aditi both, I think we are generally we have figured out this panel from, I'm not promoting anything, but MedGenome, there's this panel with multi-gene with reflex MLPA. I think what Dr. Reema also said, probably a PAL-B2 is something which I'll also be interested in.
Yes, PAL-B2 is now.
So I think this is where possibly that a multi-gene panel with reflex MLP will probably make more sense. So I've had these.
So these are the standard.
Can I just, out of my interest, all of you in the previous patient who had 2 nodes positive of yours, first of all, did you offer chemotherapy to her or not?
So this patient had a low
not
risk,
this one, the previous
oncotype.
one. The previous one.
No, the previous one had a low oncotype recurrence score, and she is on ovarian function suppression.
But then she was a premenopausal patient by definition, right?
Yes.
So
but she didn't want chemo. She has
so fair
refused
enough.
for chemotherapy.
So let's say,
So
even if
she's
let's say if she had an oncotype of 28, or like basically a borderline oncotype, what would have been your choice? 4TC, 6TC, or ACT?
So young patient, I follow 6TC. We've had the meta-analysis which says that 6TC is equivalent to 4+4. So that is what I do. Professor David, any inputs on the 6TC?
So Professor David, 2 questions to you. Do you, knowing that she's a premenopausal female, what is your take on oncotype DX considering the RX-responder data? And the second is 4 versus 6TC or ACT?
I'm sorry, what was the second question?
4TC, 6TC, ACT.
Yeah.
TC times 4 versus ACT. Sorry.
Yeah. Well, firstly, if you're talking about the previous patient, I think exactly what happened is what I said I would have done, which is to have that discussion with her with the result of the test, and I think ovarian suppression was perfectly reasonable for that individual. I'd like to make a quick comment about the last patient, because of course you didn't, because she had 4 positive nodes and so forth, quite appropriately post-operatively, I would not order an oncotype or a gene profile on her. However, in our practice, such a patient who we wouldn't know the exact number of nodes, we would know that she probably had positive axillary nodes and a large tumor, we would consider actually ordering Oncotype DX on the core biopsy that was used to make the diagnosis. And the reason, of course, would be in assisting decision-making for neoadjuvant chemotherapy. Now, you could just go ahead and give her neoadjuvant chemotherapy and be justified in trying to reduce size, but I hate to put patients through cycles of therapy to reduce the size of a tumor and waste time or even see progression if there's not value. So in such a setting, if she had come back with the last patient with a recurrence score of 40 or even 30, then it would be very easy to justify giving you adjuvant therapy and treating her to maximum benefit preoperatively.
So it's interesting you speak of that, because me and Aditi, we both work in the same institute when we've been struggling with this hormone positive locally advanced breast cancers and not getting adequate responses. So I think, Aditi, that's a fair point. I think we can consider doing an oncotype on the core biopsy and then deciding whether we need to do neoadjuvant or not. So is there a cutoff in your head which you don't do a neoadjuvant in such cases?
Is there a cutoff in which I do what?
You don't prefer a neoadjuvant? It's the standard 26.
Yes, I mean, obviously, the reason for giving neoadjuvant therapy isn't for survival outcome, because the NSABP studies have shown there's no value to that. But there is a value to neoadjuvant therapy, I think, in obviously for patients who are highly motivated in breast conservation to reduce size. And if you have a patient with a large breast, even a large tumor, you can, use oncoplastic techniques to really still remove a sizable segment of breast if you can reduce the size of the tumor to an acceptable level. The second issue is that we use neoadjuvant therapy routinely as our default position in patients with triple negative disease, because we'd like to. There are enough different options and combinations that if you're not making progress, there's no point in continuing that therapy. Then we'd like to switch to a therapy that's likely to be more effective, or at least try an alternate one. So,
sorry to interrupt. In a hormone positive, let's say the patient looks like a N2 disease, would you still run an Oncotype DX to understand the need of a neoadjuvant therapy?
For N2 disease,
4-node will become N2, right?
Yeah, that's kind of a toss-up. I mean, those are patients in whom I personally, we don't have data obviously on N2 disease. I personally believe that just as you saw in the attack data that I showed, whether you have 4 or more nodes or 0 nodes, increasing oncotype score still is relevant in terms of tumor biology, in terms of its prognostic risk. We don't have information on prediction. My guess is the additional node or 2 doesn't change dramatically the biology, and the biology is such that I don't believe they benefit. Now, we still offer all of those patients chemotherapy because you're limited in what we have to offer. I mean, this is going to be a really exciting area when you can begin to start measuring in real time tumor response in a much better way.
But if I'm not mistaken, none of these studies actually measured response rates. So it'll still be a very indirect measure to understand from the Oncotype DX score what the response will be. Yes, you know what the recurrence risk is, but the response to chemotherapy really does not come into picture anywhere. So I don't think we are there yet to predict neoadjuvant, whether neoadjuvant should be given in a certain setting just based on historical studies that have been done on Oncotype DX.
Well, actually, you're right. There's not a big prospective study looking at that, but you can look at you can use iterative deduction. I mean, we know that in take the NSABP B18 trial, which was the first one to show this, that those patients who got who got a complete clinical response or pathologic response had a better short-term outcome. Patients who had a complete pathologic response had a better overall survival outcome. And so utilizing an agent that's going to give you a response, or choosing an agent that's likely to give you a response, is obviously better than using an agent that gives you no response or in which disease progresses. And with ER positive disease, we know that there are subsets, I mean, subsets of lobular cancer and others, that actually you give them chemotherapy and the tumor kind of waves and smiles and keeps growing. So I think, and those are patients, we don't need to put them through that, or we can look at alternatives, particularly as we have more effective endocrine therapies to utilize in that setting as an alternative.
Professor David, there's one last question on the chat box. Did the Taylor RX study, can we extend the Taylor RX study to other tumor types also? Because we know that there are multiple genes which are actually looked into the 21 gene signature, which I don't know whether they are specific for only ER positive disease or for other tumor biology.
No, I don't think you can use them for, I don't think you can use that assay for other tumor types that are not ER positive, HER2 neu negative. I mean, you can use it in HER2, HER2 neu positives were included in the original validation set of B14 because nobody was measuring HER2 in the days when that trial was conducted. But all of those patients turned out to have high oncotype scores. So there's no reason to do oncotype in a HER2 positive patient. But in ER negative, true ER negative, zero ER patients, no, I don't think there's any role for this assay.
How do you guys use Monarchy in a neoadjuvant hormone positive? So if I give a neoadjuvant chemotherapy in a hormone positive setting, would you still use abemaciclib in a adjuvant setting if there's a node positivity?
So I think, Bhuvan, what we see in our clinical practice is a bit different than what the Western literature says. Our patients there are many patients who come in with locally advanced disease who receive chemo. The number of patients who are receiving chemo is increasing nowadays, but there are many patients who have not received neoadjuvant chemo and they directly go for surgery termed as large operable breast cancers. I know my surgical colleagues are going to hit on me, but I think that there is a significant number of patients who would still fit into the inclusion criteria for the Monarch, which also includes when we look, it actually looks at post neoadjuvant therapy, and maybe those patients who still have a significant residual burden post treatment, one would want to offer them that. Although the trial has not really included those, but that is one patient group where we know they are going to do bad. I don't know, Professor David, your comments on that?
No, I mean, I think, listen, I think in the end, you use the information that you have available to make the best choice. And I guess I would finish by saying that, I recognize, I see among the people discussing today your enthusiasm and your interest as it mirrors mine. I mean, we want to take the very best care we can for the patients that we have, and we use the tools that we have available. And the reality is that I am very fortunate because I practice in an environment where it has become a standard of care, and where the majority of patients, certainly the majority of patients I see, have an insurance, even if it's a government insurance for poorer patients, in which the ability to get an oncotype on anyone virtually, as long as they meet the standard criteria, is available. So I'm very fortunate in that regard, and I recognize that isn't possible everywhere. By the same token, I think we have to be very careful of not confusing. We do the best we can, but we can't always use all tools. They just aren't available. But for example, we didn't discuss it today, but algorithms or nomograms. I mean, there's been a lot of interest, and you look in the literature, there are dozens all over, from PREDICT in the UK to the McKee equations in Pennsylvania to Swedish stuff. I mean, they're every week, like weeds popping up in the springtime. There's a new nomogram, and they all are correlated against something. The problem is they're looking at populations. They're not looking at, and we don't really get information about individual patients. And I think that the information that came out in TAILORx and Responder are very illustrative. I mean, I'm sure the people at Genomic Health / Exact Sciences were very disappointed and even upset to see that premenopausal patients didn't fit this sort of mold or model of low score, no benefit, high score benefit. But that's the reality of biology. I mean, we can't just look at a few features and say, because any more than we can look at a person and decide on their ethnicity or their sex or their age that they're going to behave a certain way. And in the same way, when we look at the phenotypic expression of a tumor, we can't automatically assume we understand biology. And only, you know, in big studies, well done prospectively with, you know, really well-defined biological intrinsic markers, can we interrogate that intrinsic biology and make decisions that really are the very best. And if we can't make the very best decision, then we can use those others as long as we understand where the limitations are.
I really thank you, Professor, for a wonderful discussion. And I thank my panelists also for a great interactive session. And I hand it over to Garvit now. Garvit, over to you.
Thank you very much, Dr. Gore, and thank you to all the panelists, especially Professor David, for having taken the time out. It's quite, I know it's a early morning for you, and it's coming to be late night for us. And with that, I think we will close this. What had set out to be a 2-hour meeting has become a 3-hour meeting. And that just shows how interesting and how exciting the talks were and how the panel discussions went. Thank you very much to all of you for having taken out the time and all the attendees. And I've been told that about 250 attendees who attended this session, both from India and Bangladesh. And I think this session would have benefited a lot of them. Thank you very much to all of you, and have a very good night and a good morning to you, sir.
Thank you very much.
Thank you, Garvit. Thank you.